Good evening, everyone. On behalf of SAPN, this is me, Faiza Khan, and I'm representing Pakistan Nutrition and Dietetics Society. And we are going to organize this webinar for SAPN on behalf of SAPN. And Saima Rashid is also the focal person of SAPN. And now I would like to invite Dr. Vijay Kumar, who is the current president of SAPN, for the introductory remarks and welcome note. Welcome, Dr. Vijay.
Yeah, good evening, each one of you assembled here for this webinar. And we are very sorry about the delay of starting this particular webinar. FISA had made a lot of efforts to make it happen since 500 people has registered, and we all thought that the 500 is not able to accommodate it in the previous link. So she immediately made an arrangement with Pharma Evo. We like to thank Pharma Evo also for giving this platform, which can accommodate 500 people. So it's a very great help. And on behalf of FISA, I also like to thank Pharma Evo for giving this last minute hand to make this webinar happening. And all the members, you all know, I don't know how many of you are the members of SAPN, but I think most of you are members of SAPN. I'm very happy to see all your faces in this webinar. And SAPN, you all know, is a South Asian Association of Parental and Enteral Nutrition, where we are able to connect all the SAARC countries. I hope you all know who are all the SAARC country people: the Pakistan, Maldives, Bangladesh, Sri Lanka, India, Pakistan are the countries representing the SAARC country here in the South Asian region. And all these countries, you all know, we are having a lot of features on the clinical nutrition. And the aim of SAPN is to take this clinical nutrition to all these SAARC countries through the SAPN association happening, so that each and every one of us who are in the field of medical nutrition know about the recent developments and everything happening in the field of clinical nutrition. So with this aim, we are regularly conducting the webinar, and each webinar is taken care by the member countries. So the last time we had it by the Nepal, and this time Pakistan under the leadership of Faiza Khan. Now we are having the regular monthly webinar. And I'm very happy to participate in this webinar with you all people. And even though it is delayed, I think the speakers can make this webinar more interesting and not less than for waiting. Thank you very much once again for coming to this webinar and taking participate in the SAPN activities. Over to Faiza.
Okay, thank you, Dr. Vijay. So now we should start with our first speaker, and we are pleased to welcome Ms. Kekasha Zahra Hussain. She's in charge clinical dietitian and head of department of SIUT, Karachi, and she has over 18 years of experience in clinical nutrition and serving as a registered dietitian affiliated with PNDS. Her topic is the navigating the latest evidence and update on evidence-based CKD guidelines.
Kekasha is serving her duties as a head of the department at Sindh Institute of Urology and Transplant in Karachi, Pakistan. This is SIUT, a very renowned institute. And she is, as a head of the department, serving her practices for the past 18 years. Otherwise, she has got a very rich clinical experience over 27 years. So she's very senior clinical dietitian, and we are pleased to have her as a first speaker. So over to Kekasha.
Okay, so good evening to everybody. I just hope we have a good learning experience in the next 2 to 3 hours. I will be talking about the latest evidence in the nutritional management of CKD, chronic kidney disease. So, like you know, my aim is to go to the latest evidence guidelines, such as the National Kidney Foundation KDOKI guidelines. I will go through the Academy of Nutrition and Dietetic guidelines, as well as the ISRNM guidelines, and look how the evidence they have recommended can be translated into individual care. I aim to look at the different dietary recommendations across different stages of the chronic kidney disease and to see how the research can be integrated into real world practice for improving patient care. Why nutrition matters. Actually, nutrition is a very crucial part of managing chronic kidney disease, and it is very important in all stages while preventing while progressing, while controlling the progression of disease and managing and treating complications related to chronic kidney disease. Patients with CKD are already vulnerable to nutritional abnormalities like protein energy wasting, which the speaker later on will be talking about. And this protein energy wasting puts the patient at a higher risk for morbidity and mortality. Similarly, metabolic abnormalities like the electrolyte imbalances, like bone mineral disorders, can also these complications require specialized nutrition that the dietitian can provide, and it is essential that these nutrition plans are tailored according to the labs and the stages of the kidney patient.
Kashan, your
So
slides
if you
are
look
not
at
moving.
a slide, okay,
Yeah, Kishan, your
let me.
slides are not moving. Yeah. So if you can,
What you can do is, why don't you share my screen and I'll just tell you when to move. Is that okay?
no, but if you can share this with me on WhatsApp, then only I can.
On WhatsApp? Okay, fine.
Yeah.
Wait a second.
Or email me, whatever. But
I did
meanwhile,
email you. Wait a second.
Miss Kehkashan, I think you have opened your PPT twice. You are moving one, but the one that is showing is here is different. So you just close down one PPT and open only one. I think on your screen you have two PPTs open.
No, I don't have two PPTs actually. I have just one PPT.
Kehkashan, can you press F5 on your keyboard, please?
I have. Is it making any difference?
No. Can
I
you see
have
the
pressed
slide? Can you see the slideshow on top, just next to the animations or the transitions?
slideshow on top next to the.
Yes. You can see file,
Yes,
home, insert, draw. So press slideshow.
I did press slideshow.
Yeah, and
Actually,
I
Himani,
have.
what she is able to see is
yeah.
different
So
from what we are
no,
seeing.
no, no. Oh, can you try the from the current slide now? I know, Sunita, there is an error. There is a lag in the. No, press the from. Yes, that's right.
Yes.
Can you
Kashan,
see now?
I did not receive your PPT. Otherwise, I would have shared.
I did. I
Kehkashan,
emailed it at
Kehkashan,
info
just
at
cross
PM.
the Kehkashan, first of all, just cross the Get Genuine office, the cross it, which is the yellow line coming on the top. Then you're going to do the screen slideshow. It will cover all the aspects.
Okay. What do you want me to do?
There is a yellow line going on the top of your slide, which is saying Get Genuine office. Just cross it, then it will come to the slideshow.
Just
Now, can
cross.
you see? Has it made any difference? Is it moving?
Yes, it is moving now, at least. Yeah.
Okay. Okay.
But it is not
So
still the slideshow. Okay. Okay, you can carry on.
is it okay now?
Kehkashan, carry on.
Yeah,
It's visible.
yeah,
Easily
go
visible.
ahead.
Okay. Okay, fine. So I was discussing the global prevalence of chronic kidney disease, and more than 850 million people around the world have chronic kidney disease. And with the rise in the incidence of hypertension and diabetes, we expect this burden to rise even further. And inappropriate dietary restrictions can cause a worsening of the outcomes in these patients. So it is very important to focus on the nutrition management according to the evidence-based guidelines. So the treatment strategies vary across different stages of the chronic kidney disease. While in the earlier stages, we focus on risk reduction and treating comorbidities. While we progress on the stage of chronic kidney disease, after stage 3, nutrition interventions become necessary to manage the complications related to the disease. Okay, so the nutritional trajectory across the different stages of chronic kidney disease is very dynamic. If you're not restricting a certain electrolyte, like you're not restricting potassium in the early stages of chronic kidney disease, you may need to restrict it once the GFR falls further down. So you need to carry on assessing the patient and reassessing his labs, and the nutrition goals keep on changing according to the disease state. Okay, so if you look at the early stages, our main focus is on preventing the risk factors. Our goal is to optimize glycemic control, control weight, control and manage weight according to the ideal body weight, reduce salt and processed foods, and increase physical activity so that we can control the comorbid conditions contributing to the chronic disease risk factor. Then in early CKD, we need to control the salt intake, increase fruits and vegetables, monitor and control weight and saturated fat so that we can control proteinuria, hyperlipidemia, and blood glucose levels. But as the GFR falls, and the complications of CKD start emerging, like anemia, acidosis, fluid overload, we need to control the diet, and this is the most important stage in where nutrition intervention can actually help control and manage these problems. You need to take a look on the amount of fluid that the patient is taking. You need to control animal protein intake and optimize fruits and vegetables, reduce the salt intake, and when once the patient has progressed to kidney failure and is on dialysis, then you need to decrease the fluid intake and optimize protein foods because the patient is losing protein while dialysis. uh, Phosphorus is not very easily dialyzable, and so you need to take phosphate binders according to the dose suggested and at accurate timings, which is something that I've seen patients are very non-compliant to.
Tasha, your slides are again not moving. Can you please, like, आप इसको move करती जाएं kindly?
Is it
These are
moving
stuck.
now?
No, not moving.
Just a second. Amen. हिंदी चलेगी वो आगे. Amen. Is it moving now?
No, why don't you stop sharing and start again?
Okay. Stop sharing.
बिस्तर पे लेटी और कैमरा ऑन किए मैं पूरी पूरी बिस्तर पे सो रही है यार, ये लोग किस तरह के हैं? Yeah.
Is it moving now?
No. Natasha, if you can send it to me on WhatsApp, then I will and keep like talking on your topic. But meanwhile, I'll download and
Wait.
share it.
Okay, wait. Should I send it to your your chat? Okay. Okay, I've sent it. Have you received it, Faiza?
Kasha, yes, I have received it and I'm sharing it. Can you please stop?
Yeah. Okay.
So which slide should I keep now?
It was slide number 7.
Okay. Is it visible to everyone now?
You have to change it to
It
slideshow
is
mode.
not in the slideshow.
Is it fine now?
Yes, perfect.
Is it okay?
I guess it is.
Yes, it's okay.
Okay. Kishan.
Okay. So when we talk about nutritional assessment of these patients, it is very important to look at a comprehensive picture and take a look at the weight, the BMI, the oral intake of the patient, body composition, and not just BMI should be used to assess weight. Although BMI has been linked to mortality, but you should look at a whole picture with the body composition as well. And serum albumin may not be used in isolation as it is influenced by other non-dietary factors, although serum albumin remains a factor that can help predict mortality and hospitalization and length of stay, etc. Okay. And composite scores like the 7-point subjective global assessment and malnutrition inflammation scores are validated to use in hemodialysis patients now. If we talk about energy requirements, an energy intake of 25 to 35 calories per kg body weight per day is recommended in metabolically stable patients. This can vary according to the age of the patient, the physical activity, the body composition, and the nutrition goals. If a patient is over 60 years of age or overweight or with a very sedentary lifestyle, he may need to take 25 to 30 calories of weight. On the other hand, if a patient is underweight or has some concurrent illnesses that may require additional calories, we may give up to 35 calories per kg body weight. Now, the weight, which weight should you use, whether it should be actual body weight or ideal body weight or adjusted body weight, depends on the clinician's judgment, and you cannot just suggest one weight for every other patient. All guidelines from KDOKI to KDGO to Academy of Nutrition and Dietetics unanimously suggest a protein restriction in patients with CKD. However, we must look at this in our scenario. I feel that in most cases, the protein intake of our patients is not very adequate. And because of this universal talk of restricting protein in chronic kidney disease patients, the majority of patients who come to us are basically on vegetables like lauki, kaddu, boiled in water for months. And when they come to us, they are actually very pleased to know that they can eat something else. So I think that we should actually take into consideration our population, take a history, how much does the patient need to restrict protein, because the ISRNM does not suggest an intake less than 0.8 grams per kg body weight if the patient is not taking enough calories. So protein restriction in the case where the patient is not meeting energy requirements is not suggested. If we look at researchers, there's this one study, a systematic review of almost 25 studies, which looked at the effect of low protein diets, and they found that low protein helped in delaying the progression of disease, as well as controlling phosphorus, as well as controlling the bicarbonate. In another study done in 2018, they found that low protein diets help in controlling HbA1c, as well as slowing down the progression of chronic kidney disease without affecting the nutritional status of the patient. Initially, I remember in the 2000 KDOKI guidelines, a recommendation of 0.6 to 0.8 grams per kg was made, and they were suggesting to take at least 50 to 60% of high biological value protein. But in the latest guidelines, they have not made any formal recommendation on the type of protein, although they have suggested a shift in the animal from animal to plant protein. And they have many observational studies have shown a benefit of moving towards plant protein, not only just in cardiovascular risk, but other and overall health, but also in chronic kidney disease. However, we should take into consideration the cultural habits, food access, and patient preferences as well. This study, done in 2020, looked at the plant-based diets and its effect showed, and it concluded that plant-based diets could be very beneficial in patients with CKD. A high fiber intake from the plant sources helped the gut microbiota in reducing the production of furanic toxins, and plant anions might mitigate metabolic acidosis. Plant fats, especially olive oil, had a helpful effect in the cardiovascular risks, and it slowed down the CKD progression, as well as it helped control phosphorus better because of the lower bioavailability of phosphorus from the plant sources. Similarly, unlike the traditional restriction of nutrients such as potassium and phosphorus, now they have moved towards recommending healthy dietary patterns, because it's not just a single nutrient that the person is eating, it's the whole food. So recommendations on healthy patterns like the DASH diet, the Mediterranean diet, low carb diet have been found to be helpful in general population as well as in cardiovascular diseases. But in kidney disease, there's limited data, and researchers have only proved the role of Mediterranean diet and increased intake of fruit and vegetable in decreasing body weight, blood pressure, and net acid production in patients with chronic kidney disease. This study from Journal of Renal Nutrition in 2017 looked at the dietary patterns by the means of a 24-hour recall, and they found that healthy dietary patterns consisting of adequate fruits and vegetables helped delay the CKD progression and improve survival in patients of CKD stage 3 and 4. Similarly, this famous Crick study done in 2020 looked at the diet of patients using a food frequency questionnaire of over 2,400 patients, and they found that that moving towards a healthy dietary pattern could be considered as a strategy for managing chronic kidney disease. If we need to rethink about electrolytes. In the past, practice was to restrict potassium and phosphorus uh, blindly, and this led to very hard to follow diets which restricted many nutrient dense heart healthy foods and vegetables. However, the latest recommendations are to provide a more individualized approach. The focus is to look at the serum levels, not just advise restriction to everyone. And it actually has the benefit that it provides a more liberalized diet and has more flexibility in it. When we look at phosphorus levels, the dietary phosphorus, the body has this ability to physiologically adapt to phosphorus levels in the early stages. However, after the DFR falls below 45, you need to restrict dietary phosphorus, and this is the first step in managing phosphorus levels. However, restriction should be based on serum phosphate trends and not just a single value. You should also look at calcium and PTH levels. You should consider the bioavailability of sources like animal, plant, and additives, which they will talk about later on in the other presentation. And we should not just target on specific target ranges like earlier they used to restrict phosphorus to 700 mg per day. Similarly, for potassium, potassium should be adjusted according to serum levels, not just universally restricted. And there are many non-dietary factors that can impact serum potassium levels, which we should take into consideration before just blindly telling them to stop all fruits and vegetables. So many medications that the patients are the ACE inhibitors, maybe potassium sparing diuretics, metabolic acidosis, which has not been corrected properly, uncontrolled diabetes at a catabolic stage, and the GI disturbances can all contribute to potassium imbalances. So the strategy should be to individualize these recommendations. Similarly, for sodium, in all stages of kidney, you need to restrict sodium. It is helpful in controlling the blood pressure and improving volume control in all stages. In the advanced stages, it helps in controlling proteinuria along with the pharmacological interventions. And in advanced disease, in patients with fluid restrictions, restriction of dietary sodium can help achieve better volume control and a desirable body weight. The aim for calcium is the total elemental calcium intake of 800 to 1000 mg, including diet supplements and calcium-based binders. Patients on dialysis may need to adjust calcium intake based on the use of vitamin D and other cosmetics to avoid hypercalcemia and calcium overload. In bicarbonate, increased dietary intake of fruits and vegetables has been suggested, as it can help decrease the net acid production and slow down the rate of decline in the kidney function. In conclusion, guidelines do suggest an individualized nutrition care, and it is essential to across all stages of chronic kidney disease. International guidelines such as KDOKI, ISRNM, all align in core areas. Early dietary intervention of by controlling sodium, protein, phosphorus can help preserve kidney function and prevent complications. And a plant-based diet should be encouraged, especially Mediterranean, and increased intake of fruit and vegetables has been supported for chronic kidney disease stages. Thank you.
Okay, ji. Thank you, Kakishan.
Yep.
Thank you so much. And I think we will be taking the question answers in the end of session after the end of the presentations. And now we have the second speaker. We are pleased to welcome Ms. Sunita Rao. She's the Chief Nutritionist at NU Hospitals, Bangalore. With over 17 years of experience in clinical dietetics, she has co-authored the position paper, Perception of Protein in Critical Illness, published in the Journal of Nutrition Research. And she's a recipient of the Excellence in Clinical Nutrition Award by IAPN India, and she's a recognized leader in renal and critical care nutrition. And she's going to talk about challenges of protein energy wasting in CKD. Welcome, Sunita.
So our previous speaker very well elucidated the entire perspective of nutrition in CKD, which is obviously very complicated as there are so many factors that we take into account. And one of the factors that I'm going to be talking on today is the protein energy wasting, which is very, very prevalent in CKD patients, and especially in patients who are undergoing maintenance dialysis. So what is protein energy wasting essentially? It is the loss of body protein and energy reserves, and which reduces the functional capacity of the patient as well. So essentially what happens, what we see here is that it's just not the protein which is deficient, even the energy is deficient, and then which affects the muscle mass drastically, and the muscle function reduces in the patient in a gradual way. So this was earlier called the uremic malnutrition, and it was known by various names in various parts of the globe. However, in 2012, the International Society for Renal Nutrition and Metabolism recommended a standardized term so that this whole gamut of causes, the etiology, and the impact that it has can be recognized under one single term called protein energy wasting, that is PEW. It has the strongest risk factor because it affects the outcomes adversely, and it increases the mortality manifold. And most often you definitely see these four categories, that is low intake of food, low body mass, there is inflammation, and as I just mentioned, the muscle mass reduces, which in turn affects the functional capacity of the patient. So these four minimum features are the hallmark of PEW. Can all be muted, please? So moving forward, why are we so concerned about this as nutritionists? Because nutritional interventions at an early stage and at every stage help in preventing this wasting, and it can save lives because malnutrition kills. The prevalence is very high, and as you see, the prevalence increases as the renal function declines. As per the ISRNM data, you can see that in the initial stages, the percentage of PEW is less than 2%, whereas when patients come to the dialysis stage, the percentage of PEW drastically increases to 54%, and this was common the world over. It has the common impacts are that it increases the mortality. There is frequent hospitalization because of the frequent infections, poor quality of life, and moreover, the erythropoiesis stimulating agents don't work very well for patients who have protein energy wasting. Apart from that, just now our previous speaker was talking about the BMI. Here there is a survival paradox in BMI, or what we would generally call as the obesity paradox as well. In the general population, we see that we want an BMI and a body weight very close to the ideal body weight. However, when you see patients in dialysis, we want patients to have a slightly higher BMI because that improves their survival rates. And this is exactly what we mean by survival paradoxes. We also see that people on dialysis and even during the advanced stages of CKD have a reduced serum albumin, reduced pre-albumin, and even the cholesterol levels start dropping. This is a clear indication of PEW, and the inflammation marker CRP is on the rise. Why now, when we have to tackle this PEW, what we exactly have to know is what is the etiology. Now, the etiology is multifactorial. It's just not that there is a poor intake of food or poor intake of energy and protein specifically. That's not the sole reason for PEW. There are a lot of catabolic drivers like the inflammation, metabolic acidosis, which I will be explaining the next slide. You must have also heard of the malnutrition inflammation complex syndrome, or the MIC, the mix, where there is a hallmark feature of a low albumin and high CRP, which leads to muscle wastage, and the it is a catabolic state. And this mix is associated with mortality, which is 1.5 times more than the normal individuals, and the functional capacity also declines to a great extent. Now, what were the catabolic drivers I were talking about? The uremia-induced catabolism, because when the body is in a uremic state, the energy expenditure increases and the muscle breakdown increases, even the fat breakdown increases, which drives the patient towards PEW. There is also inflammation, which does not allow the nutrients to be absorbed or utilized in a normal way. The endocrine disorders, there is insulin resistance, there is growth hormone imbalance, and all these again promote muscle breakdown. The dialysis treatment itself actually induces a lot of inflammation, nutrient losses. We all know that every 4 hours dialysis session, there is a loss of around 15 to 20 grams of amino acids. So there is a metabolic shift, and the comorbidities that the patient already had, like the diabetes, cardiovascular diseases, and the frequent infections, all these bring the patient into some kind of a vicious cycle. Whether you break the PEW first or you tackle these underlying conditions, that becomes the question, and the patient is in a vicious cycle. So early interventions are extremely important to help the patient not get into this vicious cycle. This was one slide which very well elucidated the causes and the consequences. I just wanted to share with all of you. It is a little it is a little, a little difficult to diagnose the PEW in the initial stages because the signs are very subtle. And in these initial stages, the patient is concentrating always on the creatinine number. Is my creatinine raising up? I want to keep it at the same level. These are the thoughts the patient has, and the patient is not really thinking about nutrition, and they don't come to the nutritionist in these early stages. And by the time we see them in our nutrition clinics or in the nutrition department, there is already a significant muscle loss. And in the early stages also, there is a high rate of misinterpretation of the guidelines that our previous speaker just now so beautifully explained. And she also mentioned that, in this part of the world, essentially the protein intake is not at all adequate. So rather than restriction, it would actually be better to see if the patient is getting the amount of protein that is recommended by the KDOQI guidelines. So the well-meaning healthcare team, the family, the patients, they all actually misinterpret the guidelines, and you see patients coming entirely with no protein in their diet. Even the plant-based proteins are completely eliminated from the diet, thinking that this helps to control the creatinine. There is a very important role of nutritional assessment here. I'm not going to be talking on assessment today, but whether you follow subjective global assessment or malnutrition inflammation score, whatever form of assessment you follow, it has to be a comprehensive method where it's just not the food intake, but the biochemical parameters, the body composition measures, the functionality, and the gastrointestinal functions of the patient have to be taken into account. Now, when we talk specifically about the nutritional intake, in the initial stages, it's the low protein diet or the very low protein diet that leads the patient into energy deficit. Most often, when the patients cannot manage a 0.3, 0.4 grams per kg body weight of protein in their diet, they go into energy deficit, and they may not even be taking the keto analogs at this time. So, or the keto analogs that they are taking may not be sufficient for their body weight, because it is pretty expensive to be taking the keto analogs at the prescribed dosage. So most of these LPD and VLPD diets will be very low on energy as well. So this energy deficit is linked to around 41% increased CVD mortality per standard deviation decrease in intake. Apart from this, most often we should realize that when a patient walks into your clinic, it is not a blanket diet that we give. No, everybody may not actually require the same amount of potassium restriction and the phosphorus restriction that you think of. So in the initial stages, potassium restriction may not be required, and unnecessarily restricting these foods from the diet may again dip the energy and calorie and protein intake of the patient. These are some of the factors we have to think about as nutritionists and not offer a blanket diet. Supplements, yes, do work very well, but however, sometimes it is not tolerated for a long period, and also there will be affordability issues. The KDOQI guidelines say 0.6 to 0.8 grams of kg body weight protein in patients who are non-diabetic. And when the patient is diabetic, you can give up to 0.8 grams of protein per kg body weight. However, as I said, the patient may actually be going through a series of infections, or the patient may be an old patient, elderly patient who is already into sarcopenia. And when most of the patients in our country walk into the clinic, they may already be having a malnutrition, underlying malnutrition. So based on this, you have to adjust the protein requirements and must balance the renal risks with the nutritional preservation, because as I said, I repeat, malnutrition kills. These are the recommended dietary allowances, but on an average, when you see there is a deficit of 0.4 grams and up to 10 kilocalories per kg body weight of protein and energy in most of the patients the world over. So how do we bridge this gap? Instead of concentrating on 3 major meals, it would be better to split the meal and provide in between small snacks which are calorie and protein packed. Also, if the patient is coming to a dialysis center alternate days, it becomes easy for us to offer a high calorie protein drink or a snack during the dialysis session. And when normal oral intake does not work, of course, you have to move forward and offer enteral nutrition as a strategy, because oral supplements or formula-based feeds will meet these deficits and help in preventing PEW, especially in people who are on low protein diet. There is energy deficiency, and this can be taken care with enteral-free feeds. It has been seen that with regular oral nutritional support, ONS support, the serum albumin and BMI do improve after a couple of months of usage. Now, when you talk about dialysis patients, 1.2 grams per kg body weight, or whatever you have calculated for that particular patient based on the case scenario, can also be met with enteral nutrition or ONS if the patient's oral intake is less, and renal specific supplements will help in adjusting the electrolytes and the phosphorus. The only problem with enteral nutrition, of course, is the first problem would be the socioeconomic limitations, and also after a certain time, the patient develops something called taste fatigue. They start disliking the taste of this enteral supplement after taking it repeatedly for some time. Now, how would we move forward in a case where we have reached a plateau, where you have suggested ONS, you are looking at the normal intake, but then you're not able to reach the goals? Here, the dietitian-led monitoring and regular adjustments will be very important. Using the ONS in combination with high protein, regular, normal food sources will again help. And also plant-based and animal protein sources have to be carefully combined in a proper proportion so that the phosphorus management takes place, especially in the early stages or in the stages 3 and 4. Now, when oral supplementation and enteral feeds do not meet in patients who are not able to take orally, intradialytic parenteral nutrition does offer a support for reaching the goals of protein and energy. This intradialytic parenteral nutrition is an IV nutrition given during the HD sessions. They are amino acid, dextrose, and lipid solutions which can be given during the 4-hour dialysis session through the dialysis circuit itself. The indication should be that the serum albumin is low and there is a continuous weight loss despite regular counseling for the patient and using of ONS. It is shown that one of the RCTs essentially showed that when the patient was taking a baseline of 9 grams per kg body weight protein intake orally, but not able to meet the requirement, IDPN over 3 months improved the malnutrition inflammation score, it raised the albumin levels, and it reduced the protein energy wasting. Again, in another multi-center retrospective study, it showed that the MIS dropped from 16.4 to 14.3. However, the benefits of IDPN is seen only when taken 3 months and greater than 3 months. Definitely, nutrition is not an overnight magic bullet. So it does take time for any means of nutrition to work on the patient. However, the risk of giving IDPN is little less compared to a central total parenteral nutrition because it uses the dialysis circuit. But the only disadvantage or a limitation I can say is the cost is really high and most insurances may not be covering IDPN. Overall, if you see, you have to tackle PEW in various ways. That is early screening, personalized nutritional plans, optimizing the dialysis, because you see when patients are only on 2 dialysis per week, you see that their oral intake, food intake is really poor and the quality of life is hampered. So optimization is essential. Managing comorbidities is, especially in the early stages of CKD, is very important. Promote physical activity in these patients because most often they have this tendency that, okay, I'm not well, I'm not going to move around, I cannot do physical activity, which is counterproductive for them. Addressing psychological issues works. Then educating the whole family, the caregivers have to be brought into the team. Developing standardized guidelines moving forward, identifying biomarkers which specially predict the PEW in the future is absolutely necessary and important. So it is a multidisciplinary approach as such. The nephrologists, dietitians, psychologists, physiotherapists, and the caregivers. Sometimes this coordination between all the providers can be challenging, but when done well, it works. So in summary, I can say that protein energy wasting in CKD is very common. About 30 to 50% of the patients suffering from CKD have PEW. It is not driven just by the low food intake. It also is driven due to various catabolic conditions that are induced by the disease itself and sometimes induced by the dialysis treatment itself. The challenges are immense. Balancing The restrictions and the needs is what a nutritionist has to ideally do, have to recognize the need for the electrolyte management and protein energy requirement and not give a blanket diet for all the patients. Nutritional strategies like counseling for the specific demands during each stage of the disease is very important, and increasing the awareness of the entire team also helps. When oral and enteral feeds don't work, IDPN does help. So it acts as an adjuvant therapy when given continuously for 3 months. There is a good improvement in the MIS scores. So individualized nutrition planning, frequent assessment, and multidisciplinary coordination are the key for these patients. So these were some of the references that I did today for today's talk. With this, I end my talk. Thank you.
Thank you so very much, Ms. Sunita Rao, for an excellent and amazing presentation. That was very, very interesting topic that you have covered and very important as well. Now, I request Ms. Faiza Khan to introduce our third speaker.
Thank you, Sunita. And I hope you will be staying here till the panel discussion. So now I would like to invite our third speaker. He's Professor Dr. Salman Imtiaz, and he's the Senior Consultant, Head of Nephrology Department, the Indus Hospital, Karachi. He's the Medical Director of SAM Hospital District, Badin. He's the Chairperson of Nephrology Task Force, Indus Hospital Networks, and he's the ex-General Secretary of Pakistan Society of Nephrology. Please welcome Dr. Salman. Over to you.
Good evening, everyone. If you can share my slides. Well, thank you very much, Faiza, for this nice introduction. And I'm really very grateful to you and the SIMA for arranging such an important webinar on this very important topic. And I'm really very grateful to the SAPM for giving me this opportunity to present my thoughts on phosphorus management in chronic kidney disease. Next slide. In the last 2 decades, there is a significant improvement in the understanding of the effect of phosphorus and calcium metabolism on the CKD patients. In the beginning, it was merely thought to be a bone disease which causes cyst and fibrosis of the bone, and it's just an increase in the fracture. But later on, next slide. Next slide, please. But later on, it is recognized that it affects the soft tissue as well, and it significantly affects the blood vessels, causing the severe calcification and the soft tissue, and it leads to the calciphylaxis, which both of which have a dreadful complication. Next slide. So phosphorus in general is a very important electrolyte in our body, and it performs various functions like it is an important component of our energy source, that ATP, and it is the important component of the second messenger, the cyclic AMP. It is also have an important role in carbohydrate metabolism in the form of 2,3-diphosphorylated. Phosphorylation and dephosphorylation of the protein are also involved in the regulation of the cell function. And lastly, it is an important component of the cell membrane. Right. So how this phosphate is distributed and it is keep in balance in our body. If you can see the level of the phosphorus in our blood, which we see in our laboratory report, is 2.5 to 4.5 milligram. It is the serum level, and the phosphorus pool in the ECF is about 500 milligram. And this level of the phosphorus is stringently regulated by all 4 means. Like, for example, we know that the bone is the most important reservoir of the phosphorus, and about 600 grams of the phosphorus is restored in the bones. And there is a continuous movement of about more than 200 milligram of phosphorus from bone to the ESF. Similarly, the diet which we eat is contain whatever the phosphorus, about 30% of that phosphorus we move into the feces, while about more than 100, more than 1100 milligram of the phosphorus is exchanged between the ECF and the. Similarly, the soft tissue also contain about 100 grams of the phosphorus, and the ECF is also having this exchange of the phosphorus. And lastly, the kidney, which filtered about 700 milligram of phosphorus per day, out of which about 90% is reabsorbed from the tubules and about 900 milligram is excreted. So this balance is kept by all of these means, the internal movement and the external movement, and the phosphorus levels remain on the same levels. Next slide. Next slide, please. So, yeah. So, whatever we see in our report, this 2.5 to 4.6 milligram per deciliter of the phosphorus is about 1% of the total phosphate which we have in our body, and majority of this phosphate is present in the form of monosodium phosphate, disodium phosphate, and phosphoric esters. Next slide. So what happens when the kidney function decline? In patient with the CKD, we know that kidney has an important vitamin D. This is 1,2,5-dihydropolycalciferol, and with the declining renal function, there is a reduced level of this important vitamin, and this causes a reduction in the calcium, and this reduced GFR causes the accumulation of the phosphorus. Both of these alterations causes an activation of the parathyroid hormone as well as fibroblast growth factor 23. So body sets a new equilibrium with a low calcium and a high phosphorus, a high PTH, and a high FSGS 23. Next slide. And this laboratory abnormalities gradually manifested in the bone abnormalities and the vascular calcification, and this triad causes an increased cardiovascular death, increased cardiovascular disease in the form of ischemic heart disease, increased fracture rate, and the mortality. Next, please. So there are other postulated mechanism of the phosphorus toxicity, like for example, if there is an imbalance between the calcium and phosphorus, there will be the soft tissue calcification. There are also other indirect mechanism of this soft tissue calcification. For example, the increasing phosphorus causes the vascular smooth muscle cells osteoblast differentiation by upregulating the transcription factors. Hyperphosphatemia induces the cardiac fibrosis. It increases the PTH release. It increases the FSGF23 release. It causes the endothelial dysfunction by inhibiting the endoproduction. And lastly, it causes the podocyte injury by overexpression of the PIT1 transporter. Next. So now coming back to the phosphorus management. The first guideline was, the same slide. The first guideline of the KDIGO was published in 2009. And later on, it was updated in 2017. So the practice which we are doing, the nephrologists are doing basically the same slide. Basically is based on the same 2017 updated guidelines. But after these guidelines, various randomized control trial addressing the calcium and phosphorus metabolism have been published, and they changed the previous practices. So there is a controversy conference by the KDIGO. The next slide. Next one. So in the summer of the last year, there was a consensus conference, the controversy conference of the KDGO panel, and they review all the literature and sets a very another approach, which is very different from the thought which we have which we think previously. Next slide. So now I would like to read out the important point of this conference, because it's very important to understand, because the concept is not going to change in the future. So the key issue at the controversies conference was the concept of the bone fragility and osteoporosis versus renal osteodystrophy in patients with the CKD. The main concern was that the term renal osteodystrophy represents a roadblock to managing the fracture risk and the foster an overly PTH and calcium phosphate centric approach to bone disease management, focusing solely on the bone turnover while ignoring other critical abnormalities in the bone tissue, properties that also drive fracture risk and are not corrected by PTH and calcium phosphate center strategies. So what actually happened after that guidelines, whatever the practice was opted, but there was no significant change in the parameter of like fracture and the cardiovascular diseases. So there was, this was so the conference participant robustly debated whether a change in terminology
Dr. Salman is muted.
Sorry. So, could I read it again?
Yes, sir.
So, okay. Actually, I just copy paste this thing because it is very important concept. The key issue at the controversy conference was the concept of the bone fragility and the osteoporosis versus renal osteodystrophy in patients with the chronic kidney disease. A main concern was that the term ROD, the renal osteodystrophy, represent a roadblock to the managing fracture risk and fosters an overly PTH and calcium phosphate centric approach to the bone disease management, focusing solely on the bone turnover while ignoring other critical abnormalities in the bone tissue properties that also drive fracture risk and are not corrected by the PTH and calcium phosphate center strategies. Conference participants robustly debated whether a change in the terminology could recenter treatment of bone disease to the skeleton itself, meaning correcting bone quality defects that are responsible for decreased bone strength in patients with the chronic kidney disease. Therefore, conference participants regarded renal osteodystrophy as a part of osteoporosis spectrum. Next slide. Can you move to next slide? Yeah. So previously, the renal osteodystrophy was a separate thing and osteoporosis was a separate thing. And I believe the nephrologists solely focus on the renal osteoporosis. They see the calcium and phosphorus and the PTH level and start to manage the patient. Osteoporosis is exactly not to be considered as a domain of the nephrologist. So, but now they make they rearrange this one and make this ROD as a part of the osteoporosis. So in this next slide. So in this new conceptual framework, which moves the management from towards the personalized care in the adult with CKD MBD management. So now there are two risk factors for the patient to have the two diseases. The traditional risk factor, which all the person who is in the community have for the osteoporosis, like for example, immobility and use of steroid and use of contraception and old age, frailty and etc. like this, and the cardiovascular risk factor, which are present to everyone because of the ongoing change in the diet and the environmental changes. The other risk factor, which is solely associated because of this loss of the kidney function, the CKD associated risk factor. And we know that the CKD is entirely affect the immune system, the endocrine system, the gut ecosystem, the neurohumoral system, and the uremic toxins make their own effects. So osteoporosis, and CKD associated osteoporosis, and cardiovascular disease, and the CKD associated cardiovascular disease. So the patient who is having chronic kidney disease is actually exposed with the double jeopardy, the traditional factor as well as the CKD associated risk factor. So the previous one. So these abnormalities can be diagnosed by biochemical methods, like, for example, doing the calcium, phosphorus, PTH, and FGS23, by doing the imaging like the X-rays and CT scan and DEXA scan, especially now. The bone biopsy and the molecular diagnostics like bone turnover markers and the bone resorption markers. The next one. So now there is patient preference management should be opted, and as Kakasha and Sumita described in their presentation, that's now this patient preference is very important in the management of the chronic kidney disease. So we have to consider all sources of calcium and phosphorus, like diet and the medical therapy, the dialysis therapy, which makes this calcium in and out, and considering the effect of these two important minerals, the calcium and phosphorus, and the vascular calcification and the CKD associated osteoporosis. So now, if you talk about the diet, next slide, please. So we have already talked about, but I would like to refer this important study in which the protein was being evaluated in the hemostasis of the phosphorus, and the investigator compared the vegetarian diet as compared with the animal protein, and they concluded that, next slide, that while using the vegetarian source for the protein, there is a less increase in the phosphorus and the PTH and the FGF23. So overall, the recommendation is to use the protein and preferably the plant source. Next slide. And now coming back to the medical therapy. Till 2017, to lower the phosphorus, there were calcium-based phosphorus binder, and they emerged in those days the non-calcium-based phosphorus binder like sibullimor acetate, phosphate, and the lanthanum carbonate. So in 2017 guideline, there was more in favor of using non-calcium based phosphorus binders just to reduce the load of the calcium, and which can cause this increased calcium and phosphorus product and causes the calcification. But in the last 5 years, various trial has been conducted, especially the two trial which has been referred, this improved CKD trial and the landmark trial. Both of the trial, and in this, all of the 4 trials which compare the use of lanthanum and sibullimor and compare with the placebo as well as the calcium-based phosphorus binder, find no difference in the vascular calcification as well as the cardiac calcification in the outcome of the patient. So there is now a debate in the nephrology community again, which is the better, because the calcium-based phosphorus binder are cheaper and the non-phosphate binders are costly. So therefore, there will be a need of doing more trials just to have a clear-cut recommendation for the use of these these medicine. Next. Thank you very much.
Thank you, Dr. Salman, for a very comprehensive presentation. And I hope you will be staying here for the next talks.
Yeah.
So now we have our fourth speaker. We are pleased to welcome Ms. Himani Puri. She's the founder and proprietor of Setva NutriCare and Chief Dietitian at Apex Hospital, Nashik. A certified pediatric nutritionist, diabetes educator, and sports nutritionist. She's the author and co-author in many nutrition books. She's the reviewer at International Journal. Her topic of today's talk is integration of RDNs in multidisciplinary renal nutrition care. Welcome, Himani.
Good evening, everybody. Thank you so much, Sapan. Thank you, Faiza, for inviting me here and talking my heart about the something which we all passionately follow and we all look forward to working always towards in the future. So, being a renal dietitian, there are a lot of questions that come across to us from the patients, from the caregivers, and from the other fellow team members as well. What exactly does a renal dietitian do? How important is she, and how does she stand apart from the other dietitians or the dietitians who are looking into oncology, into diabetes, or into sports and community nutrition? So, before I start with anything, I just want to emphasize one point that making changes the diet or making changes in the food is a big behavioral change. It is a behavioral change in terms of your way of living, your way of interacting with the others, and the way you respond to your methods of cooking as well. It's just not merely a list of do's and don'ts that you eat this and you do not eat that. No. It talks about your food preferences. It talks about the changes that you have to bring into your lifestyle. It talks about the diet which you have to incorporate into your lifestyle based on your cultural preferences also. It might hamper, it might hinder, or it might improve your interaction or social activities with the others as well. Because especially when I'm talking about a renal patient, if somebody is coming to me and we have recommended him or her a low protein diet, but his or her friends are somebody who are heavily into non-vegetarian food, then how do we turn about the or modify diet so that he or she is able to eat well, enjoy the company of the friends that they are going out with? So it's not just about giving a list, but it's about managing their entire social and personal life as well. By the end of the sessions in the evening today, you had speakers before me, you would have speakers after me. We are hoping that you would be able to recognize the critical role of dietitians in the continuum of renal care. You would be able to understand how nutrition intervention is impacting CKD progression. Before me, Dr. Salman spoke about the management of the minerals in the diet. Sunita spoke about the protein management in the diet. I'm talking about the renal role, and then there are speakers after me also talking about the importance of various aspects of nutrition in the renal management care. Uh, In my presentation here, I'll be also talking about how we can incorporate dietitians so that we get a much more better and efficient clinical workflow, which aims towards the benefit of the client or the patient health, and try to identify the barriers which can bring about a better renal teamwork, which is much more efficient. So why dietitians really matter in the renal care? Um, Before I start with why, I just want to give you a brief explanation about the various types of diet that are available in the CKD management. We have been knowing about the plant-based diets, we have spoken about low protein diets, we have spoken about very low protein diets, we talk about low sodium diets. I have people now coming with me that they want to follow a keto diet, but then they are CKD stage 2 or CKD stage 3. Then you also have intermittent fasting. So all these are the diets, various diets which are available in the market for everybody to follow. As a dietitian, if a client is coming to me and asking me for certain factors or certain parts of diet that they want to follow, how I can do it and what I can do is where the dietitian knowledge and the dietitian role come into play. So yes, so the dietitian should be aware about the different types of diets that are available, the different concepts of diets that are available. She should be able to discuss with her or his client about disadvantages of each and every diet, what are the pros of the diet and what are the cons of the diet. So that is where the dietitian comes into picture. We all know that CKD is a big group of comorbidities. You might have the patient coming with diabetes, you might have a patient coming with heart failure, or maybe some liver changes also. You would see a lot of inconsistencies in the availability of the nutritional assessment. If the patient is on dialysis, you might see a weight gain happening on the days when there's no dialysis and lesser weight on the days when the patient is undergoing a dialysis. You might also see a lot of variations happening in the advices that are being given to the client about the or the patient about the nutritional recommendations. Somebody would ask him, oh, you have kidney disease, you should not be eating any proteins, and then they stop eating all dals or lentils. And then somebody would say, oh, you have kidney disease, so you should not be drinking a lot of water. And then sometimes we actually have a patient coming up with us with dehydration. So these all challenges, small challenges, actually contribute to a bigger, larger complex clinical deficiencies and complexities in a renal patient. Also, one thing which I have been always talking about is that being a renal dietitian, you should you should be able to discuss each and every single aspect. One, with the patient, second, the caregiver, and third is the physician or the nephrologist who is looking after or taking care of the patient. Because unless until we are talking to all three of them, we would not be able to get the best results or the best outcomes. So, a renal dietitian always focuses on evidence-based medical nutrition therapy, whether the patient is a CKD patient, the patient is on dialysis, or we have a post-transplant patient. The dietitian looks at protein energy wasting. She has to or he has to look at the electrolyte imbalances. You have the potassium levels going up and down, you have the sodium levels going up and down, you might be seeing calcium and the phosphorus levels also going out of the normal limits. We might have to give fluid restrictions, but then sometimes you might actually have to become little liberal with the fluid intake if the patient is starting to doing well. We have to be looking at the nutrient drug interactions. A lot of drugs come with a lot of challenges with nutrient absorption, so that has to be educated to the patient as well. We also need to be looking at the gut microbiota. It's a big area in itself where we should be aware about how the gut health improves the health of the patient and what we can do for that. So, what are the various points where a renal dietitian can come across or integrate with a renal patient? It could be in any outpatient nephrology clinic where you are dealing with patients from stage 3 to stage 5. A dietitian could be incorporated in the dialysis centers or in the home modalities where we have the patients who are doing home-based dialysis. Also, she could be incorporated into the ICU settings or the hospital settings where we might have AKI cases more, or we might be seeing end-stage renal disease complications. And very important, post-transplant. Usually, once the transplant has happened, 1 month, 2 month, 3 month down the line, the patient becomes quite relaxed. The patient becomes quite easy on their approach with their care for the diet, and that is where majorly the dietitian comes into role, because we see a lot of complications actually happening post transplantation. So as you can see here in the cartoon, we can see that these are the areas where a dietitian can work with dialysis patients, with hospitalized patients, with long-term care, with CKD patients, with transplant patients, and basically with anybody else other than that as well. So how can we collaborate with the other team members? One, incorporate yourself into the referral pathways, maybe by a physician triggered reference, because that is the easiest contact. The patients consider doctors their god. So whatever the doctor says, the nephrologist says, the patient would follow. So that becomes a very easy access for a dietitian to associate, to collaborate with a nephrologist or get referrals from them so that you are able to get involved into the paths of the renal care or the journey of the renal care of the patient at an early stage. Probably you could develop your own interdisciplinary team, which would have a psychologist, maybe a social worker as well. You could have a nurse there. You could always have a fitness trainer or a health expert who is experienced with the physical health aspect of the patient, so that you can explain the patient about the exercises which he or she can do during that journey of renal care. Also be involved in documentation and planning of the emergency medical room systems. Again, it's very, very important that whatever a dietitian is doing, the notes have to be written. Whether you are in a hospital, whether you're in ICU, or whether you are seeing a patient for an OPD. If a patient is being referred to you by a nephrologist or a physician, there should always be a note written back to the referral doctor or the physician stating what you have done and why you are doing it. If the patient is in the ICU, you should have your notes in the patient files explaining what you are giving and why you are giving it to the patient, so that it becomes easy and understandable to the other team members also and are equally involved in the process of diet management. So, following protocols, following proper case studies actually helps us in getting successful results. So, what can be the major triggers for nutritional therapy references? Anybody with a new diagnosis, anybody with a declining kidney function, anybody coming to you with a hyperkalemia, high phosphates, or hypernatremia or hypokalemia, anybody who has a high blood pressure, or anybody who has a question to be asked from a dietitian should be easily referred to a dietitian for the nutrition therapy. And remember, this is for every physician and for every health worker involved in the renal care, that printed renal diets do not work. An individual normal plan is always much more better than the pre-printed renal diet charts that are being handed over to the patients, usually in the OPD settings. Community and interprofessional dynamics is very, very important for a dietitian. Me as a dietitian should be able to communicate what I am giving and why I am giving. I should have a big clarity about my role, and also I should be able to respect interprofessional relationship. That is something again we have seen. Lot of dietitians who are coming now, they do not interact much, they do not talk much, they do not explain themselves much. And also, as a dietitian, you need to have your set boundaries as well. There are certain things which you can do with the diet, but not 100%. You cannot cure the person 100% with the diet. And always remember, if anything goes wrong with the health of the patient, the concerned physician is in charge of the health. He is responsible and he is answerable for the health and not you. So, whatever you do, you have to be discussing and approving with the concerned physician or with the nephrologist before prescribing. So, collaborate with the physicians, nurses, discuss it with them. Probably you could also talk with the other health professionals and go for community or group sessions where you are able to address the common concerns of everybody, so that you are able to have a much more better dialogue with the patients there. So, what can we expect by improved outcomes or improved clarity of communication with the patient, with the fellow health workers, and with yourself as well? We would, of course, be seeing improved patient quality of life, reduced hospital admissions, better biochemical markers, and most importantly, better adherence and better response from the patient where diet is concerned. You would see that the patient is following the diet much more better than what he or she was following initially. But then, other than, in spite of doing all this, we sometimes do come across certain barriers. These barriers could be personal barriers, or these could be the barriers coming from the setting where you are working. The barriers could be from the staff shortage. It could be getting limited reimbursement as a dietitian, getting paid less, probably time constraint. You have too many patients and lesser time, and that can affect the quality of your counseling. Also, you might need to be focusing on certain strategies where, again, as I said previously, that you get more referrals from the nephrologist or from the fellow health workers for consultation. So there was this beautiful study which was done, and they spoke about what are the barriers and facilitators for assessing medical nutrition therapy in CKD patients. And what they found, the major barrier was lack of renal dietitians, lack of insurance coverage, and low reimbursement rates. So I think insurance well is not in our hands. We cannot do much about it because it depends upon the insurance companies. But probably we could focus on working on the low reimbursement rates, talk to your fellow workers again, increase your knowledge, improve your knowledge. The more knowledge you have, the more you discuss again, probably you would be seeing a much more footfall, and you would be seeing the doctors discussing the things with you more. And what are the facilitators? That you start with the referral programs, probably start organizing um, camps where you can identify potential CKD patients. That can again give you a little leverage, or maybe bring you into the limelight of knowing that yes, this is where I can probably go because I am on the threshold of developing a renal disease, and develop positive perception about the medical nutrition therapy in renal conditions. So I would just want to end my talk with a small case study which I have borrowed from one of the nursing centers. I have changed the name here. So Sunrise Nephrology Center SNC is a medium-sized outpatient dialysis facility, and they were experiencing high rates of PU, low adherence to dietary restrictions, and recurrent hospital admissions in CKD and dialysis patients. Can I request to mute, please? So while they were seeing these observations, the medical management was very positive about the nutrition services, but then they were really little confused as to what they can do, and therefore they approached a dietitian to look into all these factors. So what were the problems that were identified? That there was fragmented nutrition care, there was no regular routine dietary assessment pattern being followed, there was not much interdisciplinary coordination happening between the fellow health workers, and as a result, a poor dietary adherence was being observed in the patients. Also, probably because the nutrition care was fragmented and the dietitians were not available on a regular basis. So what they did, they started developing a weekly interdisciplinary rounds. That is, a dietitian would always go along with the nephrologist when the rounds were happening. She would always be accompanied with a nurse or a social workers when the rounds were being taken, so that whatever discussions were happening regarding the patient health were happening in front of the patient and the caregiver. The patient was getting a better insight about what has to be done and how it is to be done and why it has to be done. Also, since the nurse was available during the rounds, she was able to make sure the diet was being followed or being consumed by the admitted patients. A referral protocol was put into place. That is, if the potassium levels, for example, went above 5.5, immediately a call was given to a dietitian. Or if the report showed a albumin level less than 3.5, immediately a call was given to the dietitian. So this standardization automatically made sure that the patient was being referred to the dietitian immediately, and there was no lapse happening between the lab reports and the patient diet management. Also, regular sessions were being arranged uh, with the support of nursing staff, for nursing staff, and for the patients and for the patient caregivers also. These frequent monthly sessions were able to help re-emphasize the importance of nutrition, re-emphasize the barriers that the patient was facing while following while following diet, and they were able to address most of the issues that the patient was facing while they were following the diet. So this is something which I have borrowed from one of the studies, but this is what again was implemented again gradually, about getting to knowing the patient, getting to knowing about his or her cultural preferences, biochemical parameters, his or her education level, social level, economic level, taking in their dietary intake, qualitatively also and quantitatively also, planning up a comprehensive nutrition plan for them based on their assessment, based on their intake, based on their GI, based on their physical activity level. After that, the assessments were done again to check them for their weight loss or journey in the weight, change in their dietary pattern, and functional status also was checked, where they were checked objectively for their hand grip strength, for walk test to analyze their muscle strength, where they stand with their muscles, and what we need to do to improve their muscle strength. And this was the outcome observed in 12 months. The albumin level of the patients before was almost 42% lesser than 3.5. It improved to just 18%. The dietary adherence, which was 35% before, improved to 78%. The readmissions happening, or the hospital admissions happening exclusively because of diet, was 12 per year, which reduced to 4 per year, and patient satisfaction index increased from 3.1 to 4.7 out of 5 in 12 months. So, what were the lessons learned? That a dietitian presence in routine team helps increase nutrition visibility, helps improve coordination, helps improve better adherence of the patient to the diet. Administrative referral programs definitely help to integrate diet into the routine renal care of the patient. And the challenges that the dietitians were initially facing from the physicians also got reduced. The challenge of time constraint of the dietitians also got improved because the other team members were also involved. And in spite of a lot of load of the patients, the dietitians were able to take help of the nurses and the social workers and the patient family caregivers as well to get a better outcome or adherence from the diet. So, lastly, I would just say that integrating dietitian is not a luxury, it is a necessity. We should not label dietitians as being only page 3. It is something who is required right from cooking food or selecting food to consuming the food. It is a structured collaboration, and we can improve CKD outcomes, reduce healthcare burden, and empower patients to take control of their own health and nutrition by educating them well and by integrating dietitians at the initial level of diagnosis of CKD as well. Thank you so much. Thank you.
Thank you so very much, Ms. Himani Puri, for a wonderful and very exciting talk and highlighting the importance and role of an RDN in multisectorial and multidisciplinary approaches, how we play our part, and you have covered your topic very nicely. Now, moving towards our fifth speaker for today's webinar, Ms. Shifa Ali. She is working as a senior clinical dietitian at Ittefaq Hospital Trust, Lahore, Pakistan. And she has done, after her master's in food and nutrition, she did her master's in public health and PGD in dietetics, and providing her services for the past 14 years. She is also a public speaker, and she is going to talk about nutrition management in potassium and phosphorus for CKD patients. Over to you, Shifa.
Thank you, Ji. Assalamu alaikum. Am I audible to everyone?
You are.
Okay, Ji. So let's start with the very important topic. मुझे जो topic दिया गया है, this is a very particular kind of a niche in this renal management, dietary management of renal disease. So hyperphosphatemia is often Thank you, Ji. Thank you. Hyperphosphatemia is often seen in patients when the GFR falls below 60 ml per minute. but many patients would benefit from limiting their phosphorus intake to a certain degree if the GFR is below 60, but it becomes absolutely mandatory if the GFR falls below 25 ml per minute. So the therapies which are suggested to control, slightly inaudible, okay. The therapies which are suggested, treatment strategies which are suggested to control serum phosphorus include a low phosphorus diet, correct use of optimal phosphate binders, and appropriate dialysis techniques. I would be focusing more on how a low phosphorus diet would be helpful in managing hyperphosphatemia in kidney patients. So, first of all, the phosphorus requirements for a renal patient should be limited to 1 gram of phosphorus per day. But it really depends on the serum levels of the patient. If the serum levels are particularly high, then we might be needing then we might be needing to limit it to 700 to 800 as well, but that demands a lot of restriction in a lot of food groups. So the low protein diet which are usually required in a renal patient of 0.6 to 0.8 gram per kg body weight comes with the phosphorus control as well, because usually the foods which contain good amount of phosphorus are also high in protein. So for the non-dialyzed patient, we want to limit the phosphorus intake to 0.8 to 1 gram per day, and for the dialysis patient, this amount might go up to a certain bit, although phosphorus is not always very efficiently removed in all dialyzed patients. So we have to see to the serum phosphorus values, despite rather than limiting phosphorus for similarly in all the patients. Next slide. So the first of all, we have to see which foods are rich in phosphorus. So the three main groups which give phosphorus in our diet are animal foods, plant foods, and food additives. Food additives are the ones which give the most bioavailable phosphorus to diets, and they are almost 90 to 100% bioavailable. Animal foods have a better bioavailability, 60 to 80%, and plant foods have a limited bioavailability of phosphorus. Sorry. So the organic sources of phosphorus includes natural foods of plant origin and animal origin, and about 40 to 80% of this phosphorus is absorbable. Inorganic phosphorus comes from food additives that is added to processed food to extend shelf life, and acidity regulators and antioxidants, and they are commonly found in various fast foods. The dilemma here is many of the labeling protocols do not require the phosphate additives to be mentioned on the labels. So many times if a patient is using a lot of processed, bottled, canned, packaged foods regularly, their phosphorus intake might go up, and also they would be taking that kind of phosphorus which is 100% absorbable. So that might be an issue in itself without their knowing that their phosphorus intake is high through their diet. So the plant phosphorus, which is an organic form, is why is it low? Why it has less bioavailability is because of the presence of phytates in it. Phytates are binders, so the intestinal absorption is particularly low, which is a good thing. Which is a good thing in the sense that this gives us the margin to include more of the whole grains, whole wheat. I would like you to particularly see the comparison between. I have mentioned various. Sorry, I haven't. So I was talking about this slide. So the plant phosphorus is in the form of phytates, and it has a low bioavailability. I have mentioned here various foods per 100 grams of various foods, the phosphorus content per 100 gram of various foods. I would like you to see the comparison of whole wheat flour, it contains approximately 315 milligram of phosphorus versus the wheat flour that has been refined. It's approximately 1/3 of the whole wheat one. But this does not mean that we always have to give refined flours, because many renal patients are also suffering, are also having diabetes mellitus. In fact, many of the nephro issues are because of diabetic nephropathy. So the diabetic patients might be needing a little higher amount of fiber. So it is up to the renal dietitian to wisely select foods which are appropriate according to the condition of the patient. If the patient has gastroparesis or chronic constipation issues, or has high fiber requirements, it is not wise to regularly include refined wheat flour or refined grains just because it is low in phosphorus. They should be taking phosphate binders with it to lower their phosphorus content. Also, I would like you to appreciate that pulses and lentils are particularly high in phosphorus, uh, but their phosphorus is less bioavailable because of the presence of phytates and because of the plant phytates. So the kidney disease and improving global outcome guidelines did not state a specific limit, and states that aggressive dietary phosphorus restriction is difficult. And I think it is not very much necessary, because it has the potential to compromise an adequate intake of other nutrients, especially protein. So as a former co-speaker mentioned, excessive unnecessary restriction of protein can lead to malnutrition. And there was a question regarding sarcopenia in CKD, which can be indeed a very grave concern in these patients. So protein should not be unnecessarily limited in these patients. So is the phosphorus, I would like you to see the phosphorus content of animal foods. Dairy foods are particularly high. Dairy foods are particularly high in phosphorus content. And egg whites versus egg whites are are a lower source of phosphorus. A whole egg with the yolk, can have more phosphorus. Also, the cola drinks, which are very regularly taken in large quantities by Pakistani population or Indian or Asian population, in fact all over the globe, can have a significant source of phosphorus, which is 100% bioavailable. And I would like here to mention here, the dark colas are particularly contains phosphorus, but not the white ones or the other colored ones. So if we Acha, I'll say it here. Acha, strategies to reduce dietary phosphorus intake include protein restriction, which comes with the renal diet. G. So the protein restriction that comes in with the renal diet can be very helpful, because it automatically limits the intake of the meal of the food. Acha. Second point is limit high phosphate foods. This is a very important point. We have to limit high phosphorus containing foods, especially there is a phosphorus to protein ratio, which should be limited to less than 16 milligram of phosphorus per gram of protein. I'll discuss it in detail in the next slides. Plant phosphorus is less absorbed than animal foods, so plant phosphorus can easily be included, because it has many benefits coming along with it: antioxidant rich, fiber rich, and many other things, satiety value, many other things are there. So whole grains should not be excluded just because they are high in phosphorus. Small quantity of them can be easily managed in a renal diet according to the condition of the patient and the serum values. Phosphorus in cola drinks should be seen whether it has to be included. Cola drinks or any such sharbats type foods can be an easy source of protein-free calories for a renal patient who is struggling for caloric intake. So orange, if if a patient wants to have some such kind of drink, orange and white sodas do not contain phosphorus, and they can be given in limited quantity if fluid requirements are being met adequately. 15 minutes are very less to elucidate each point, but each of the point is very significant. I personally believe this renal diet, making renal diet is like a plain canvas, and you have your brush, and you have to paint your own painting according to the condition of the patient and serum values and the medications and everything and the comorbids. So boiling foods also reduces phosphorus content of the diet, and the degree of mineral loss is proportional to the amount of boiling. The more the boiling water, you have to discard the water, cut the vegetables or the meat in the small sizes. Cooking time will also reduce the phosphorus contents. Acha, there has been a study on it that just boiling the foods in large amount of water and discarding the water can reduce the amount of phosphorus to 50 up to 51%, from 38 to up to 51% without the loss of proteins, precious proteins. I would say precious proteins, because proteins are very important for the renal patient. So phosphate additives have to be avoided. You can memorize or you can look for these E340, 349 numbers. They are used for acidity regulators, thickeners, but the dilemma, once again, I would like to say is they are not always labeled on the packaging, which can lead to which makes them a hidden source of phosphorus. So a person who is taking a lot of processed packaged food might be increasing their phosphorus intake unknowingly. So this is an extremely important point. Extra burden of phosphorus coming from processed food may reach 700 to 800 per day. And as I mentioned earlier in the first slide, for some patients, the total requirement for a day might be only 1800 milligram. It might not be even 1000 milligrams. So and also if we are relying on phosphate binders, that phosphate binders will manage that extra phosphorus. So phosphate binders can remove no more than 200 to 300 milligram of phosphorus per day. So you have to limit those processed food and eat more of homemade fresh foods. National Kidney Foundation clinical practice guidelines recommend a daily phosphorus intake of 12 to 16 milligram for phosphorus per gram of protein. Phosphorus to protein ratio, this means more natural selection of a more natural diet that is more easier to reach acceptable phosphorus to protein ratio of less than 16 milligram. Because a high phosphorus to protein ratio was found to be associated with an increased mortality risk in patients on hemodialysis, the risk being the greatest in those who had a total dietary phosphorus to protein ratio of greater than 16 milligram. अब आप ये देखिए next slide में ये देखिए, I have copy pasted some lists. You can find this document for yourself too, and you can make your own diet from here. If you are planning a diet, select the foods in the red box which have a lower phosphorus to protein ratio lower than 16. Those foods are more appropriate to be added in a phosphorus rich diet, in a phosphorus in a low phosphorus diet, sorry. So you can see that the milk, whole milk and goat milk have the highest phosphorus to protein ratio. 30 to 26 milligram per gram of protein, which is one of the highest. Egg, I would like to mention here, egg whites have the lowest phosphorus to protein ratio, 1.42 only. So if we have to add a source of protein which does not give does not give phosphorus or mineral phosphorus, these are the egg whites. I would quickly skim through these. Here are the lists of meat and poultry. Meat and poultry also have low phosphorus to protein ratio, 9, 10, 11, 7, 8. You can see this for yourself. We have very limited time. Cereals also have various ratios. Some of them have higher ones, especially the processed packaged ones, some जिनमें additives डले हुए होंगे. those will have higher phosphorus to protein ratio. Any food that will be processed, packaged, might be containing phosphorus and as an additive. So legumes also, some of the legumes also have higher than 16 phosphorus to protein ratio. Nuts and seeds have a very high ratio, so they have to be included in the diet very cautiously, seeing the serum values. Another important, interesting thing that I learned about is the phosphorus pyramid. The food pyramid, just like the food pyramid, it's a visual tool designed to present the phosphorus load of various foods. I don't have much time to explain it, but this is how the foods have been shown visually and limited. But it has a very interesting explanation for diabetics, for potassium, and for other things. The foods at the base of the pyramid can be take in a bit more servings, but the foods at the top of the pyramid have to be limited. I think the food at the top, most top, are foods with additives, so they have to be restricted, I guess, totally. And at the left side, the advice has been given to boil the food and discard the cooking water. Dietary management of potassium, I'll quickly go through this because of the limited time. 2 to 3 gram per day should be limited according to the serum value. There might be hyperkalemia, and the patient might also be having hypokalemia because of the overuse of potassium losing diuretics. So you have to see, not all renal patients suffer from hyperkalemia. Hyperkalemia can lead to serious arrhythmias of heart and can lead to serious conditions, but hypokalemia can also lead to serious consequences. So you have not every patient has a hypo or hyperkalemia. You have to see the lab values. You have to learn to see the lab values. Potassium is found in almost all foods. Plant foods have a bioavailability of 40 to 60%. This is due to fiber and phytates. Animal-based potassium is highly bioavailable up to 90%, and 100% potassium is absorbed from food additives. So in both of the minerals, potassium and phosphorus, we are seeing that plant-based diets can be included just because of the low bioavailability of the minerals present in them. So this makes them kidney friendly. Most of the water soluble, yes, that would be. But in fact, phosphorus and potassium management are absolutely direly needed in these conditions, because these lead to serious diseases, and they increase the risk of cardiovascular diseases, bone diseases, and hyperkalemia can be life-threatening. Foods that are higher in potassium are defined as which are having more than 200 milligram of potassium per serving. And the size of the serving that you eat is very important. A large amount of a low potassium foods can easily turn into a high potassium food. So if there is a fruit which is considered low potassium, like an apple, if a renal patient eat 4 apples a day or 5 apples a day, it will make it a high potassium food. So potassium content of animal foods should be considered while planning a diet, because it should be limited for hyperkalemic patients. It should be limited to um, less than 2 gram per day at times. And for hyperkalemic patients, you should also know the potassium content in per serving of any food, because in hypokalemia, one serving of high potassium food at a time should be given, and then not necessarily you should include all the high potassium foods at once for a hypokalemic patient. So again, dairy is a high source of potassium, and chicken and egg are on the lower side of the potassium. There might be other reasons for hyperkalemia in a renal patient, which constipation can be one of the important reasons for raising potassium levels in renal patients. So if you are over limiting fiber in such patients because of the fear of increasing their phosphorus intake, you might reconsider your choices. High blood glucose levels might also increase potassium levels. Some medications, herbal and vitamin supplements should be considered. Moringa or any such supplements. Sometimes, I remember now, curcumin supplements are very high in potassium. Missing dialysis or not having enough dialysis, high acid levels, muscle breakdown, and rapid weight loss. That protein energy malnutrition, over restriction of protein. Sometimes we get a request for a dietary consult with the request of nil protein diet, which is, I would say, a criminal and in criminal negligence. Fruits, vegetables are specifically high in potassium, so you have to select the foods accordingly. But I am of opinion that high potassium fruits can be sometimes included in a diet which has a range of 2 to 3 milligram potassium, if small amounts are given just for the sake of increasing variety in the diet or the palatability of the diet, or patients are many times suffering from taste fatigue, or they just like to taste a new seasonal fruit. So इतना restriction उसके अंदर बहुत मुनासिब नहीं है कि आप बहुत ज़्यादा उसको पेशेंट को बहुत ज़्यादा ओवर रिस्ट्रिक्ट कर दें और वो interesting foods ना खा सके. Vegetables, there are many lists available on National Kidney Foundation, Penn Nutrition, which can be used for the planning of low potassium diets. How to reduce potassium in diet? Be mindful of portion. That is very important. I believe every food can be included in a low potassium and low phosphorus diet if you know how to control the portions and mix and match them according to the likes and dislikes of the patient. And we don't want to deprive the patient because already their taste is the taste is affected. Also, they are suffering from sometimes they are suffering from dysgeusia, anorexia, malnutrition. So eat as everything can be given in small portions. Eat smaller portions of meat and milk, but they should be included, not totally avoided. Avoid potassium additives. Additives should be avoided at all costs because they give 100% absorbable potassium. So if the patient has hyperkalemia, then only go for fresh homemade foods. Beware of salt substitutes. Salt substitutes like right salt, light salt, they should not be given for to renal patients who are at risk of developing hyperkalemia. Ready to cook meals, chicken nuggets, pies, these come with these potassium additives. So processed cheese, these might be some herbal and potassium vitamin supplements. Once again, every kind of potassium herbal supplement, greens can be high in potassium. Cooking vegetables, uh, thank you, Hajra. Cooking vegetables and meat in a large amount of water and discarding. Peeling the fruits and vegetables can reduce the amount of potassium. Cutting into smaller pieces, grating or shredded increases the surface area of the food, and then cooking in large amounts, this will also reduce the potassium. Yes, I agree that vitamins will also be lost, but potassium can be very detrimental for the patient. तो फिर वो आपको लैब वैल्यूज देख के ही चलना पड़ता है. स्वैप कॉफ़ी, मिल्क शेक्स, जूसेस टू मेनली वाटर, ये स्वैप्स ऐसे इजी स्वैप्स हो जाते हैं फ्रॉम हाई पोटेशियम फूड्स टू लो पोटेशियम, कंसिडरिंग का आपका फ्लूइड इनटेक कितना है. एम फॉर 2 servings of fruits must be included. I have seen many nephrologists working with me or elsewhere who totally restrict fruits. I don't agree with that. Pakistanis are very fond of fruits. Please let them eat fruit, and especially seasonal fruit. आजकल आमों पे बड़ा सवाल हो रहा होता है कि जी प्लीज आम खाने दें, आम खाने. तो आप उनको बता दें quantity, mention the quantity. They don't tell them the dire consequences of increasing their portion sizes, and they will stick to it. So aim for at least 2 servings of fruits, 5 servings of vegetables per day because it will give adequate fiber. Fiber will also help with their constipation, which will also help remove the excess वो serum values. Extra food जी बिल्कुल ऐसे ही है. Be mindful of concentrated forms, for example, soups, juices, dry fruit. These are very high sources of potassium. In a limited amount, they can give very large quantities of potassium. And swap to fresh options. Fresh options have more water content. So this was a very interesting point. Exercise, but I know that this cannot be applied to very critical patients in the hospitalized and admitted in the ICU. But for OPD type patients, who have the risk of developing hyperkalemia, they must exercise. Exercise to lower potassium. Regular exercise can assist with potassium levels. Aim for 30 minutes most of the week. Exercise helps with your bowels remove those के फायदे हैं ना. It will help to regulate your bowel movements, so the excess potassium might be excreting out, and the muscles will use potassium, so the serum values might be in check. So that is all from my side. This is a very lengthy topic, but I have tried to be as precise as possible. Thank you very much.
Our pleasure to have you, Shifa. As a speaker, I know it's really very difficult to summarize a huge topic in a nutshell, but you did a good job. Thank you so much. I hope
Thank
you
you.
will stay with us.
Thank you. Ji.
Okay, now we have our last speaker, Professor Dr. Deodatta Shafikar. He's a distinguished MD and DNB in medicine and nephrology with additional fellowships from prestigious international societies. Dr. Shafikar is the director and consultant nephrologist at the Supreme Kidney Care in Nashik, a professor of medicine, and has held leadership positions in both the Indian Society of Nephrology and Indian Society of Critical Care Medicine. Welcome, Dr. Shafikar, and over to you.
Okay. So thank you for the invitation and happy to be a part of SAPIN group. And in the last presentation, we already heard the nutritionist perspective of management of phosphorus and potassium. And I will try and give you the nephrologist perspective as far as this problem of hyperkalemia is concerned. Uh, Yeah, so my slides are visible. Okay. So let me talk about the problem of hyperkalemia. So all of you know that the kidneys maintain body fluids and electrolytes and acid-base homeostasis. And a lot of ESRD patients, they develop hyperkalemia. We know that potassium control is very crucial in patients who are having chronic kidney disease and all those who are on dialysis. Remember that dialysis alone may not fully control potassium, and we need a lot of other strategies also. Now, typically, hyperkalemia is caused by a loss in the plasma membrane integrity or a reduced secretion of potassium into the urine by the kidneys. So, normally we know that the potassium is an intracellular ion, and in hyperkalemia, it goes outside the cell. So total body potassium distribution, 98% is intracellular, 2% is extracellular, and the kidneys have the work of maintaining the potassium balance, and they also influence the potassium excretion. Also remember that some of the renal patients, they have hypokalemia, which was mentioned in the last presentation. So we need to be very, very judicious as far as the potassium management is concerned. There are a lot of medications which can cause hyperkalemia, and the clinical presentation is also varied. So if you have a potassium dysregulation, then there are many pathophysiological causes for hyperkalemia. So first of all, the kidney function goes down. There is a reduction in GFR causing impaired potassium excretion. There could be a tubular dysfunction causing reduced potassium secretion. Chronic metabolic acidosis causes a transcellular potassium shift, and that causes hyperkalemia. Some people have insulin resistance, and that results in impaired cellular potassium uptake. There are some medications like the RAS blockers which cause hyperkalemia, and altered gut potassium sensing pathways. It also contributes to the hyperkalemia. So how do you define hyperkalemia? Remember that the incidence is actually 5 to 10% of hemodialysis patients, and it can result in an emergency dialysis in almost 24% of ESRD patients. A lot of patients, they can die because of severe hyperkalemia, especially those patients who are on hemodialysis. Now, in dialysis patients, many times hyperkalemia is because of the excess potassium intake. It can also be related to inadequate dialysis, or if the patient is skipping dialysis. Sometimes it can cause potassium shifts. like in metabolic acidosis or rhabdomyolysis or muscle breakdown. And there are some medications like ACE inhibitors, ARBs, and NSAIDs, which can also result in hyperkalemia. Now, what are the potassium targets as far as CKD stage and the renal replacement therapy is concerned? In pre-dialysis patients, remember that in stages 3 to 4, usually you target between 3.5 to 5 milliequivalents per liter and between 4 to 5 milliequivalents per liter. Remember that in dialysis patients, your pre-dialysis potassium should be less than 5.5 milliequivalents per liter. In those patients who are on peritoneal dialysis, the limit is 3.5 to 5.5 milliequivalents per liter. There are some controversies in targets because the DOBS data again showed that these targets may be different in different populations. Whenever you have a rise in potassium, it can be due to acute causes. And acute causes are many. Some of them I have already enumerated. If you have acute hyperkalemia, then you can have life-threatening ECG changes in the form of peak T waves and a prolonged PR interval. And sometimes you can have cardiac arrest followed by preceded by ventricular fibrillation. So most of these patients initially have bradycardia, junctional rhythm, QRS widening, and then peak T waves. So the severity of hyperkalemia can be defined by way of the potassium levels. So potassium between 5 to 5.9 can be termed as mild if there are no ECG changes, but if there are ECG changes, it is termed as moderate. If the potassium is between 6 to 6.4 without ECG changes, then it is moderate hyperkalemia. But if there are ECG changes, it's severe hyperkalemia. And anything which is more than 6.5 is surely severe hyperkalemia. So just as you have causes of acute hyperkalemia, you can have chronic hyperkalemia, which is there for a long period of time. Again, it is related to chronic use of medications, or it can also be related to delay in dialysis. Remember that the mortality curve is U-shaped as far as potassium is concerned. Both hypo and hyperkalemia can cause mortality and increased risk of dying. Now, management strategies are many, which I will elaborate later. As far as the problem of hyperkalemia and prognosis is concerned, remember that there are some life-threatening arrhythmias which can occur and you can die because of cardiovascular events. Also, chronic hyperkalemia can also lead to progression of renal damage, and it also leads to a lot of healthcare costs because of chronic admissions and mortality. Now, the symptoms of hyperkalemia can be many. You can have decreased reflexes, tingling all over the body. You can have hyper or hypokalemic paralysis, muscle weakness, abdominal distension and bloating, and nausea. Now, if a patient is on an ARB or angiotensin receptor blocker, then as the stage of CKD worsens over a period of time, the incidence of hyperkalemia also worsens over a period of time. In pre-dialysis patients, remember that the incidence of hyperkalemia is there, but it is usually related to the diet as well as medications. So you need to really look at the dietary modifications in pre-dialysis patients to prevent hyperkalemia. Now, as far as dialysis patients are concerned, remember that if your dialysis is inadequate or the potassium is not removed on dialysis, then you can have post-dialysis hyperkalemia because of redistribution. Many times, peritoneal dialysis also provides a slow potassium removal, and again, that can also result in chronic hyperkalemia. There is a term called as pseudo hyperkalemia, where the potassium levels are falsely elevated. Actually, the serum potassium has not risen, but it is a misdiagnosis because of various causes. So, what are the types of pseudo hyperkalemia? There is something called as reverse pseudo hyperkalemia, where the plasma potassium is falsely elevated, typically in the hematological malignancy cases. So if you have a patient of blood cancer, you can have a falsely high potassium levels. Similarly, there is a condition called familial pseudohyperkalemia, where it's a genetic condition, it's a rare disease called as a leaky cell syndrome. But what are the clinical implications? Remember that diagnosing pseudo hyperkalemia is a challenge, and in those patients, you might treat the hyperkalemia wrongly and cause hypokalemia. And therefore, you must rule out pseudo hyperkalemia right from the word go. What are the causes of pseudo hyperkalemia? There is, if you have hemolysis in vitro, then you can have rupture of red blood cells during blood collection, which causes a falsely elevated potassium levels. Simple things like a fist clenching and muscle contraction during phlebotomy, or a delayed sample processing in the laboratory, or improper temperature storage of blood samples, or contamination with potassium from EDTA tubes can also cause pseudo hyperkalemia. Now, if the lab results are inadequate, obviously you are going to make a mistake while treating the patient. And therefore, proper blood collection, avoid fist clenching, use the correct needle size, avoid hemolysis, process blood as early as possible, store at ambient temperature. These are all simple things which you can do to prevent pseudo hyperkalemia. And remember that the dialysis prescription is also important in dialysis patients for optimization of potassium management. Hemodialysis factors, the dialysate potassium is very, very important, and one has to look at the dialysis potassium along with the treatment time of dialysis and the frequency of dialysis. Also remember that there is a difference between hemodiafiltration and conventional hemodialysis. But rapid potassium shifts can cause increased cardiac risk. In patients of peritoneal dialysis, the dwell time is important, and whether the patient is on a cycler or whether the patient is on continuous ambulatory peritoneal dialysis. So this is about, in general, the causes of hyperkalemia in patients who are not on dialysis but who have CKD, and in those patients who have dialysis, who are on dialysis. Now, there are a lot of nutritional strategies which have been elaborated in the last presentation regarding potassium control. Obviously, diet is very, very important. Dietary education and telling the patient to be very, very compliant as far as the diet is concerned. And there are some medications, and balancing with other nutrients is very, very required. Now, every patient of CKD should undergo a detailed nutritional assessment as it is shown in this particular flow chart. And you have to find out whether the nutritional status of the patient is normal, or is the patient malnourished, or sometimes the patient can be overnourished. Now, after looking at the BMI and the ideal body weight, and you have assessed the dietary protein intake, you have categorized the patient as having CKD, then look at the serum electrolytes, and if you find that the potassium is high, then obviously you are supposed to look at the diet and advise the patient accordingly. So this is a comprehensive assessment approach where you have to quantitate the dietary potassium intake by a 24-hour recall versus a 3-day food record, and you can have some digital tracking tools to find out whether the potassium intake is proper. Always look at the medications which the patient is taking, because there are some medications like potassium sparing diuretics, beta blockers, and RAS inhibitors which can cause hyperkalemia. Metabolic parameters like acidosis and glycemic control has already been mentioned. Bowel habits, constipation, and GI function has also been mentioned. Also remember that the dialysis adequacy metrics like KT by V and the residual function is also very, very important. Now, there are some diuretics which are having a caliuretic action. That means they lose potassium in the urine. So you can use these drugs in order, if the patient is passing urine, then you can use these drugs to lose potassium in the urine. So loop diuretics like furosemide, bumetanide, or thiazide diuretics like chlorthalidone and indapamide are very, very useful, and they are important to treat hyperkalemia. There are some other approaches, other medications which can treat hyperkalemia. So you have potassium binders, which we are using in clinical practice. The most common binder is sodium polystyrene sulfonate, which is a cation exchange resin, and it exchanges potassium for calcium and ammonium in addition to magnesium. Similarly, you have the calcium polystyrene sulfonate, it exchanges calcium for potassium. There are two new drugs which are available to us now. One is called as petiromer, which is a non-absorbable polymer consisting of smooth shears of the active moiety, and that also is a binding resin. And the next drug is the sodium zirconium cyclosilicate. Again, that will be available to us in the near future. Remember that there is a concept of gastrointestinal potassium wasting. So potentially in the future, probably you can try and find out whether you can lose potassium by way of the GI wasting. As the kidney function declines, the potassium wasting through the urine may reduce, but through the GI tract it may worsen. So therefore, in the future, you can have a role of the gut microbiome and its relation to the potassium homeostasis. So there is a lot of evidence as far as the colonic potassium sensing and secretion is concerned, and you may be able to increase the fecal potassium excretion by various medications by way of a prebiotic and probiotic intervention research, and that is how in the future you can use that strategy. But there is a nutritional paradox as far as the end stage kidney disease management is concerned. Remember that there is a paradox between protein energy wasting versus potassium restriction. Also, there is a difference between plant protein intake versus the potassium levels, fiber intake versus the potassium levels, phosphorus co-restriction complexity, which was discussed in the last two presentations, and you need to have a risk stratification approach, and you should have individualized patient approach which will not hamper the quality of life of the potassium. It's important to emphasize that a plant-based diet can be advised as far as the problem of hyperkalemia is concerned, because it reduces the net acid production, reduces the metabolic acidosis. It can also give you dietary fiber and treat the constipation. Again, these are all measures which can treat hyperkalemia. There are a lot of evidence-based dietary interventions in the pre-dialysis patients which are shown in multiple studies. So sometimes you can advise the patient a Mediterranean diet which can be suitable to him in his own way, or you can advise a DASH diet. In hemodialysis patients, remember that you have to restrict the potassium to 2 to 2.5 milligrams per day, and the timing in relation to the dialysis session is also important. Also remember that the KDOKI guidelines have already been mentioned. Now, I will not go into great details as far as the food items are concerned, because it was discussed in detail in the last presentation. But remember that the potassium additives and all the processed foods are a strict no-no, and the high risk foods, moderate risk foods, and the low risk foods have already been elaborated. Leaching methods have also been told to you, whether cold water soaking or a hot water soaking or a double cooking can give rise to 60 to 80% reduction in potassium. But remember that the other nutrients should be preserved during processing. Again, there are a lot of foodstuffs which are high in potassium, and some of the foodstuffs, like some vegetables, have a low potassium, and the bread and cereal products also have a high potassium intake. Some of the dairy products can also have high potassium. So you all are much better trained as far as these food items are concerned. So therefore, I am not going to elaborate as far as the food items are concerned. But remember that whenever you want to estimate the potassium intake, then you can do it by various ways. You can do a dietary recall, or you can do a food frequency questionnaire, or you can do a spot urine collection to find out the urinary potassium excretion, or you can do a 24 hours urinary collection to find out how much is the potassium excretion. So therefore, the dietary potassium recommendations are very clearly seen for everybody, and we should follow these recommendations which are by the KDOKI guidelines. So every patient should undergo a comprehensive nutritional assessment and try and undergo the proper advice. Also remember that there are a lot of salts which are available which are high in potassium. Again, this point was mentioned, but in this particular chart I have given you the potassium content which is there in table salt, in the pink salt, in the senda namak, then the baking powder, etc., ajinomoto, etc., etc. So therefore, one has to be aware of the potassium content in various types of salts. So at the end of the day, you have to individualize patient education strategies because dietary counseling is very important. You can have use some digital tools versus a traditional approach for management of hyperkalemia. Motivational interviewing techniques. Remember that give them a lot of exchanges because then the whole process becomes less boring. Timing of intervention related to CKD progression is very, very important. The family also has to be taken into confidence, and the health literacy considerations in diverse populations is very, very important. So therefore, this is an interdisciplinary care model. It's a team effort, and you have to use the clinical decision making tools as far as these patients are concerned. So in the future, we'll have some novel potassium binders in development. There are some gut targeted therapies. There could be some wearable potassium sensors which could be available in the future for continuous potassium monitoring. Then every patient is different, so you need precision nutrition approaches. There could be AI based machine learning for hyperkalemia prediction, and there is some dietary pattern research in CKD cohorts in various countries, and this can individualize the potassium targets based on the patient's profile, and you can have a balanced nutrition approach in addition to potassium restriction and optimize the dialysis prescription for the same. So at the end of my talk, this is a flow chart for management of hyperkalemia. You have to do the ECG. You have to find out if the risk of potassium related issues is very, very high. You give the right drug therapy, manage, and you can do an emergency dialysis. And these are the approaches for the management of chronic hyperkalemia, dietary potassium restriction related to lifestyle. Permissive approach can also be taken. Discontinuation of medications, use of potassium wasting diuretics, mineralocorticoid agonists, GI potassium wasting can be thought of. You can use some potassium binders, the both new and old. Thank you very much for your attention.
A very, very special thanks, Dr. Shafikar. Your presence is highly appreciated. Thank you so much for your valuable insights and covering this topic in a very nice manner that you covered all the aspects regarding CKD management in an excellent, efficient manner, and your experience is really reflecting in your presentation. Thank you so much. We are highly privileged to have you as a speaker on board. Now the forum is open for question and answers, and we would love to have some questions from the chat box as well, because there are so many questions, but most of the speakers have already covered so many questions which were there in the first and second presentations. And thank you so much for the patient participation in the session, because for the past 2.5 hours we are connected, and it's a big deal. Although some of the participants they do disconnected, but we have a huge number still with us. So the first question from we can start with Dr. Shafikar, that as early diagnosis of CKD is always very important. So would you highlight in our part of the world, as being living in middle income and lower middle income countries, what are the barriers would you suggest, or would you think that are there in early diagnosis of CKD?
So I think there are a lot of barriers as far as early diagnosis is concerned. Remember that when you answer this question, we need to know the causes of CKD. And in our part of the world, causes of CKD are probably related to diabetes because that is the highest incidence, followed by hypertension, followed by infection related chronic glomerular diseases. So, whenever you have these situations, then you have to be very, very vigilant as far as effect on the kidneys is concerned. So every diabetic individual must undergo a thorough screening at least once in a year to find out if the kidneys are getting affected. The same is true with patients of hypertension. And same is true with patients who have recovered from acute kidney injury. Some of them can go into chronic kidney disease. So I think these are the three main things, three main diagnoses where CKD can progress or CKD can occur, and we have to be vigilant. The second important thing is the education level as far as our population is concerned. We need to educate our people so that we need to make them aware of the incidence of chronic kidney disease generally in the society. And you know that we are celebrating World Kidney Day every year, and on such occasions we do try and educate the general public regarding the functions of the kidneys, the importance of kidney damage, and what happens when the kidneys are damaged. So I think these measures will go a long way to find out whether early CKD can be diagnosed. Also remember that the blood tests are very simple. You can just do a serum creatinine, you can just do a urine examination to find out if there is any urinary abnormalities in the form of proteinuria, and therefore if you do that judiciously, then early diagnosis of CKD can be made.
Thank you, Dr. Shafika. These are the all genuine concerns. Um, do we have Dr. Salman here? Dr. Salman, are you there?
Yeah.
Okay. So my next question is, how frequently do you see malnutrition among CKD patients, and how do you manage malnutrition among CKD patient? And obviously, we know it that the early diagnosis of CKD is always missing thing, and when patients reach to the nephrologist or the kidney care center, they are already very late, and a lot of uh, losses have been occurred, and their muscle and protein loss, muscle losses have been already they are going through these losses and with the multiple comorbidities. So what is the, considering the situation in Pakistan and India, I think is somewhat similar. So if you want to comment on this.
You are right. Malnutrition is a problem because of these dietary advices which we have from the community and from the doctors. But I found there's a difference in the malnutrition. Like for example, in our rural areas, this protein malnutrition is very common. But in the cities, like in urban areas, as the diabetes incidence and the obesity and other problems are there. So there is a significant number of the patient who, when they first referred to the nephrology clinics, they already lost a lot of renal function, and because of their loss of appetite, they are malnourished. So counseling them, you all know, is very difficult, because if you ask them to just increase their nutrition, their protein intake, there are limitations. I mean, the economical limitation and the beliefs about the diets. So, as it is mentioned that the dietitian role is very important, because for a nephrologist in a busy clinic, it is very hard to give a detailed perspective of the diet. So I think it's very common to have these patients with malnutrition. And the second problem is to encourage them to eat the healthy diet because of so many limitations. So I think there must be a collaboration, like in our hospital, a dietary and a nutrition clinic is there, so it's very easy to refer the patient. And since our hospital provides the nutrition to the dialysis patient and the patient who on maintenance hemodialysis, when I calculated protein meal is given to the patient as well. So I see a lot of difference in the patient who dialyze in our center, because they have a good access to the nutrition as well as the nutritionist as compared with the other centers. So encouraging them to have a healthy diet is the answer.
Okay, Dr. Salman. Yes, you are right. Like now, I would ask Sunita. We have Sunita here, and Sapna Kamdar has also joined the panel from India. And the next question is how do plant-based and animal-based protein impact protein energy management in the CKD patients? As we have already discussed that a lot of patients, they have very low intakes of animal protein as far as when like what we see in Pakistan. Uh, Most patients, they are. Can you please mute your mics? So mostly we see patients that they are already malnourished and their intake of protein, like animal protein, is very low. And as they were, they were restricted by many healthcare providers in the like if they are going through the treatment for the last 4 to 5 years. So every person is advising them different uh, like suggestions for diet, and some doctors suggested them to reduce the vegetable protein intake, to reduce the lentils, and some are avoiding like some are advising them to avoid the animal protein intake as well, especially in the early stages of CKD. So and especially in the India and Pakistan, like there is a emphasis on the animal based to reduce the intake of the animal based proteins in the from the Western guidelines, I would say, because the situation of Pakistan and India is different. Like we don't consume that much protein as animal protein, just like West. So in such situation, how do plant-based and animal-based protein impact this management of protein energy wasting? Um, yes, Sunita, would you like to comment? And then we will ask Sapna Kamdar for the same.
Sure, sure, sure. So it all depends upon how we wisely proportion the plant-based proteins and the animal-based proteins. It is a myth to say that you have to completely avoid animal-based proteins, because this would actually have a detrimental effect on the patient's nitrogen pool in the body. We've discussed so much about protein energy wasting today, and I was emphasizing even there that it all depends upon the proportion or the portion sizes in which both are combined to form a meal, which will give around 0.7 or zero point 0.8 grams of protein per kg body weight. Especially, we see a lot of diabetic nephropathy in this region, in this part of the world. So it would be wise to actually include both types of proteins, but of course, including too much of red meat would increase the uremic load. When you choose poultry and even egg whites for that matter, in everyday diet, in a small portion, egg whites can be easily included in everyday meal in an appropriate portion based on the patient's requirement. So that would help. And in fact, Faiza, we see that even the lentils are avoided by many doctors. They when they come to us, they are only on a cereal and a vegetable based diet. There is no lentil, there is no dal at all, and there is no question of non-vegetarian protein. So that needs to be regulated, and by the time you actually convince the patient that it is absolutely necessary, that itself is a task, because they kind of are scared that their creatinine levels will increase. So work on the plant-based proteins and then slowly include the animal-based proteins in small portions at frequent intervals, even if not every day, in frequent intervals through the week. But egg white can definitely be included every day. And this, even right from the initial stages, will go a very long way in preventing PEW. And it does not really increase the potassium load if it is appropriately portioned.
Okay, thank you.
Potassium or phosphorus load.
Yes, you are right. Absolutely. So there is a question, how do serum albumin levels always be the nutrition marker? Because of sepsis, trauma, and inflammation may also cause decreased albumin levels, which are we always going to check our nutritional management effectiveness in albumin levels. And what are the strategies? What can be the strategies for improving anemia in CKD patient along with the CKD and diabetes? Because the anemia is because of the lack of erythropoietin, and most of the time people are like have misconception that so what is your comment on this, Sapna? Sapna, are you there? Yeah.
Yes, yes. A very good evening to everyone. Thank you, Faiza, for this wonderful program, I must say, with very good speakers, and I've been hearing all of them talk. Um so before I jump onto your question, I would like to address the previous question, as in the plant and the animal-based proteins, as we were rightly discussing. So sadly, if you see the population on a larger front itself, they are already deficit in protein, and when they come to us, they are already in the compromised stage of malnutrition and not eating well. And on top of them, as you rightly said, they come with a lot of misconceptions and myths about uh, not eating a certain class of food. But understanding the basic importance of benefits of eating a plant protein or a plant versus the animal protein really makes a difference. And I think it's our duty as qualified dietitians, renal specialists, to actually train and educate our patients and tell them what are the pros and cons of eating a certain kind of protein. So when it comes to plant proteins, it helps in getting the other vital micronutrients. It reduces the uremic load, the acid load of the body. And as Sunita also rightly mentioned, that not worrying too much about the potassium and the other electrolytes, because we as dietitians, we plan the meal, which is very individualized, customized as per the patient's need. And portion is something that we need to concentrate on. So the portion control and rightly curating the meals that fit for that particular patient works well. Uh, Coming to malnutrition and albumin, it's the basic marker that we use as an assessment when we assess malnutrition in patients. And it's very important that early diagnosis and early assessment at the earlier stages really helps to overcome the tragedies that happen due to PEW in most patients. Because uh, sadly, when they come to us, they are already, as I mentioned, in the compromised state, and the assessment never happens unless we probe those kind of blood parameters and tests that we do, or the scoring, the malnutrition scoring that we do, wherein we get to know the status of albumin, blood albumin levels. And again, taking care of your food intake via the right kind of foods, the animal proteins, which are in portion control, with portion control, the right kind of foods like egg whites, and other albumin sources that can be included, along with certain nutritional supplements, which are the direct sources of albumin that really works well with patients. And we've seen better patient outcomes with patients who are on albumin and good quality proteins that they take over a period of time, or a longer period of time. So it's not just a short period or intervention that we are recommending, unless the patient is acutely managed in a hospital. But otherwise, somebody who's on a chronic management, then you need that consistency in the diet, the compliance, and the right knowledge that needs to be given to the patient with right kind of meal planning that really helps in management, I think.
Yes. Yes, you are right.
Raisa, I would
Certainly
like
right.
to add to this.
Yes, sure.
Essentially, when she was asking about why albumin is a marker when there could be a shift in the serum albumin because of the inflammation and the acute other conditions.
Yes.
She rightly, actually, the question is very well put. See, that is the very reason why we don't say serum albumin is the only marker for malnutrition or PEW. It is always suggested or recommended that a comprehensive assessment is made. So serum albumin is not a single marker, definitely,
Yes.
because it is a acute stage, acute phase reactant.
Yes. Sunita, you have also a vast experience in the management of kidney patients. So, how often do you see IDPN used as a part of treatment for the uh, dialysis patients? Because what we see in Pakistan, it is not much prescribed. Although the patients are deteriorating with time, and their intake is hardly like within under 800 caloric per day, within like even more less than 800, 600 or 500, up to 500 calories also. I've seen patients, but they are not prescribed IDPN as an option. And most of the time we see a lot of such kind of patients who are losing weight, their condition, their functionality is disturbed. But when they when it comes to the IDPN, I hardly see any nephrologist prescribing this. So I would ask the same question with our nephrologists also who are here. But first, I would like you to comment on this. So how frequent do you see IDPN management, successful IDPN management among patients which you are dealing with in India?
Yeah, in my setup, because it's a private hospital and we see patients who are able to afford it, so we do IDPN. However, if you look at a larger population, IDPN is very expensive and most insurances may not cover it. So the use of IDPN, that is the main reason why use of IDPN probably gets limited in the larger population. And also, it's not like you do 1 or 2 transfusions or 1 week. It, as I said, it takes over 3 months of continuous use of IDPN to see that shift in the, all the parameters, nutritional markers. So giving IDPN for even a month would be a very heavy cut on the pocket for the patient unless it is supported by insurance. So probably this is popular only in setups where it is affordable. That's the main thing. We see it in private setups, but in probably also where there is some kind of a support, a funded support in larger establishments where research also happens. There is some kind of support funding from research institutes. So there also IDPN happens. But you are right, actually, it is not as popular as it should be because it helps. It does help. We have seen patients who have benefited from IDPN.
Okay, yeah. So I would ask the same question with Dr. Salman, if you are here. So what is your take on this? The use of IDPN it is very less prescribed. I would say not prescribed at all, or in very critical situation when the patient is not going to survive. We know that, and at that time at the last management, nutrition comes always when like they have tried everything and nothing is working, and then they ask the nutritionist to come and plan for that IDPN or TPN or
You are right. One reason is already been told by that the cost is very important thing. We use intradialytic therapy in the patient who are critically ill, and then ICU they spend more days and they are malnourished. But for the maintenance hemodialysis patient who came from the home and for dialyzed twice in a week, I think I experienced. I mean, sometime when I used it, I come across with some problem because I think this osmolality of this TPN needs to be adjusted because you are giving it in a very short span period of time. This liter and 2 liter of the fluid in 4 hours. Some of my patient has severe irritability and they develop hyponatremia and after this ADPN. So I think the prescription was wrong. I mean, the prescription was not right. We use the same IDPN which we used to give in certain hours in this small period of time. Well, so my experience is with you when I was in the kidney center, and I used to ask you to prescribe the ICPN. But later on, I really, I mean, I was not comfortable to use because of this. Some of the patient deteriorated because of this therapy. I don't know why. I was thinking it might be because of the hyperosmolarity of the nutrients, which causes an acute shift of electrolytes in this patient and causes this hemophilia. This is the reason I'm not proud of.
Faisa, you're muted.
Yes, Dr. Salman, there is another question relevant to you. Why don't we have peritoneal dialysis common in Pakistan?
Peritoneal dialysis is now becoming common because in Pakistan we started peritoneal dialysis in Indus Hospital and CAPD and APD both, and in Lahore, Bahria Hospital also started this one. So there are 3 or 4 centers, and now one of the Pakistani engineer developed a cycler for the peritoneal dialysis. So we have the Pakistani fluid and the Pakistani cycler. So the peritoneal dialysis will increase definitely, and where our aim is to make, as in other countries like Sri Lanka and Malaysia, to make this hemodialysis as a first treatment, rather peritoneal dialysis as the first treatment as compared with the hemodialysis. These are the problem because of several reasons, because the hemodialysis is prevalent, and the corporate sector has seen more benefit in establishing the hemodialysis center than this home-based treatment. And there is a need of government support actually in Canada, in Europe, and in other countries. The government is behind the peritoneal dialysis program. So I think if they understand, the government understand these things, then we can establish, like for example, in our rural areas, it is very hard to develop the hemodialysis unit, the infrastructure, the human resource, and the equipments. It is very difficult to establish the hemodialysis in the region of Thar, like for example, the desert region. And I know majority of the patient died there before reaching to the hospital, even seeing the hemodialysis machine. But if we can establish a peritoneal dialysis program, we can reach to the door of the patient to give this therapy. So I hope so. Peritoneal dialysis will develop in Pakistan. Then we will come across with new challenges which we are not facing actually dealing with the hemodialysis and peritoneal dialysis is different. So there are reasons not to have peritoneal dialysis that common. And recently we have this very good symposium in which the people from Sri Lanka, Malaysia, and Bangladesh were gathered, and they have their experiences, and all have the same feeling that there is some restriction to expand the program. But everyone is optimistic that one day will come, then we will have PD as a first round.
Okay. So next quick question I would have, what are the micronutrients, which micronutrients are of concern? Because when macronutrient intake is compromised among patients, so definitely there is a deficiency of micronutrients as well, which is affecting the patient's, metabolism and like many processes. So which micronutrients are of special concern, which you see in your practice? I would ask Sapna to comment briefly on it, and then Sunita. And if you have Kekasha also here, Kekasha, please join the panel.
Yeah.
Yes,
So as
Sapna.
we all know that kidney has very many roles to play, right? Our kidneys have very many roles to play in various metabolism of vitamins and minerals in our body. And when it comes to CKD patients, we see a lot of deficiencies of vitamin D, calcium, phosphorus. All of these homeostasis have been, imbalanced. And that's the reason we focus more on getting or providing these nutrients like vitamin D, which has a major role in our bone mineralization, and besides that, calcium, phosphorus. And we see most in the senior elderly CKD patients, wherein we see more chances of getting fractures or falling or frailty that occurs because of these deficiency. And besides that, of course, we know iron is a very, very major nutrient which is of a concern because of the generally patients correlated with low hemoglobin levels. And it's lack of awareness that erythropoietin is basically, which is leading, the CKD itself is leading to low hemoglobin levels, but we need to replenish these vital nutrients as well. Besides that, we see a lot of zinc, selenium, vitamin C and B vitamins for that matter, because as we see, when we recommend too much of leaching or patients in hyperkalemia, we see the water loss, the loss that happens of the water soluble vitamins. So we need to replenish those vitamins as well. And besides that, I would also want to emphasize on the use of probiotics and prebiotics in these patients, which are again very vital for gut health, because we see a compromised gut health in these patients as well because of the existing comorbidities and the impact of the disease itself, which is causing a lot of dysbiosis in patients, further worsening the CKD, outcomes. So when we talk about, to sum up, it's iron, it's zinc, of course, of its antioxidant properties, selenium, B complex vitamins, iron, folic acid, vitamin D, and calcium, of course, plays. I think we as dietitians should also concentrate on providing a well-balanced meal plan, focusing, and of course, nephrologists also prescribe additional vitamins and supplements, which is mandatory, because just the food may not help as much, and we need those additional nutritional supplements to replenish the stores. So this is what we need to concentrate on.
Yes, exactly. I agree. Yes, Sunita.
Yeah, so when you actually talk about the early stages of CKD, because of overall, reduction in the appetite and or reduction in the food intake, there are renal friendly micronutrient supplements that are given. But however, what everybody here should remember is that it is not same as any of the over the counter multivitamin tablet, because the dosages in which the multivitamins and minerals are given for CKD patients are very different. For example, if it is vitamin C, you cannot be taking just like people during COVID took 500 mg of vitamin C and things like that, and zinc and vitamin D supplements. That cannot be done in patients with CKD, because it will have quite a detrimental effect. Too much of vitamin C causes hyperoxalosis. So any multivitamin supplement that is considered safe for the kidney will have a monitored dose of vitamin C, and water soluble vitamins, as long as they are passing urine or they are not anuric, is fine. Most often we have stopped actually advising leaching unnecessarily because of this very reason, that they lose a lot of vitamins unnecessarily. Unless it is absolutely necessary for this particular patient to be leaching their food, we don't advise leaching in general. It's not like a rule for everyone that leaching has to be followed. So that way we actually can contribute to their overall intake of multivitamins and minerals through the diet itself. Then when it comes to vitamin D and calcium excesses is not required. However, vitamin D, you see, again, in this part of the world, most of us, even probably people now who have joined this webinar, have a vitamin D deficiency. That is such a common thing. So vitamin D supplements are prescribed by the doctor, by the nephrologist, and that has to be taken, because overall the vitamin D, calcium, and phosphorus monitoring is required to maintain that mineral bone disease or prevent that mineral bone disease. Once the patient comes to dialysis, here there is definitely a loss of water soluble vitamins due to the dialysis itself. So it is mandatory for them to take water soluble vitamin supplements. This is given in general, and diet has to be optimized. They may not be able to take too much of nuts and seeds, which are the main sources of zinc, selenium, and chromium and other things. But if you include whole grains as much as possible, these can be replenished.
Yes,
and it needs to be done under supervision, is what as Sunita rightly said, it cannot be like an OTC supplement that you can take. It has to be done under correct guidance of a nephrologist and under a qualified dietitian.
Yeah, definitely no over-the-counter supplements for any of these.
Yes, agreed. Shifad, are you here? We have a question for you as well. If
Yes,
Shifa is
I'm
here.
here. I can answer. Yes, I
Okay.
can answer.
So we had a quite relevant discussion about different nutritional concerns or issues, and definitely there are certain misconceptions also which are quite prevalent uh, among our healthcare providers as well. Like, we are not talking about the general public, but among the healthcare providers, there are certain myths about certain nutrients which we face. Like, like whoever is practicing as a renal dietitian, they usually counter these kind of concerns in their daily practice. So what the public health initiatives are needed in our country, if we talk in general, to improve the CKD awareness and early detection, and to improve the um like for the better patient outcome, I would say, or to improve the quality of patients quality of life among CKD patients and dialysis patients, because we see a number of dialysis centers being open, and a lot of treatment options for dialysis is now available, and they are increasing day by day. We all know about the statistics of how CKD is spreading. uh, but what kind of initiatives we need to take as a lower middle income country? uh, what kind of initiatives we need to take as a nation, or the health community? We should emphasize on that. Would you like to comment briefly on this?
Yes, there are a lot of myths spreading around renal nutrition and the things which lead to renal failure actually, and this leads to a lot of malnutrition. The myths are surrounding myths surround around various kinds of animal foods, plant foods, things to include, and medicate the use of medication. One thing I would like to comment: the one of the major causes of renal failure can be hypertension. So this emphasis on quitting the hypertensive medication can lead to dire consequences in some of the some of the patients. Also, uh, glycemic control of diabetic patients can lead to nephropathy. So the myths around not taking medication, not taking timely insulin can also lead to a lot of health burden, economic burden. And I think renal dietitians have to work in a lot of aspects because the renal patients come with a lot of comorbids. Sometimes liver is involved, sometimes heart is involved, sometimes there are other things, surgeries. So I must say there's a lot of work to be done, and a renal dietitian should be an integral part of this whole HCB team working in dialysis unit, because most of the time many of the foods are overly restricted, which can easily lead to malnutrition. The simple common myths surrounding around the usage of chicken and broiler chicken and eggs can lead to over restriction of protein, can lead to over restriction of even lentils and pulses, and people are just consuming starches, breads and boiled vegetables. Sometimes sometimes diet can be very unpalatable with over restriction of spices as well, unpalatable diets. And sometimes patients are driven towards usage of यूसेज ऑफ अननेसेसरी फूड आइटम्स जो बहुत सी ऐसी चीज़ें हो सकती हैं जिनमें प्रोसेस चीज़ों की तरफ उनको लगा दिया जाता है. So that can put a real burden on patient economic burden of condition of our Pakistan. I think dietitians should be an integral part of all the hemodialysis centers, because this can actually improve the outcomes of the disease, improves the malnutrition condition of the patient.
Yes, thank you, Shifa, for your comments. And the last question from Kekasha. Kekasha, you are here. That just a quick recap on the use of coconut water in CKD patients, because as being a part of living in South Asian countries, it's a very common practice to have coconut water. So what's your opinion on it?
We have just 3 minutes. We have just 3 minutes left. Kekasha, can you please briefly comment on this, and then we will have the closing remarks.
Well, actually, you're right about coconut water, and it is actually considered something very nutritious and beneficial. But it is true that I've actually seen that it works best for hypokalemia. I think the best strategy to improve your potassium levels is giving coconut water. So obviously, we need to restrict it, and we tell our patients not to take it.
Thank you so very much. I'm very much thankful to all the panelists for their valuable comments and making this webinar a real success, because we are receiving so many excellent comments regarding this webinar. So for the closing remarks, I would like to call upon President of Pakistan Nutrition and Dietetics Society, PNDS, Ms. Rabia Anwar. I please request her for the closing remarks.
Thank you, Saima, and a very good evening to everyone. So thank you everyone for joining us for this amazing and very informative session. So I really extend my sincere thanks to all the participants for joining. And this session brought together valuable insights on chronic kidney disease management, highlighting the importance of evidence-based nutrition care and regional collaboration. I want to thank all the colleagues from India, especially Ms. Sonita, Ms. Himani, Ms. Sapna, Dr. Shavakar, and from Pakistan, Dr. Salman, Kehkashan, and Shifa for sharing their expertise, and to all the attendees for their active participation. We are also grateful on behalf of PNDS to South Asian Association of Parenteral and Enteral Nutrition, SAPN, a dynamic organization that brings together healthcare professionals from Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka to promote excellence in nutritional practices. We are honored to be part of SAPN. At the end, special thanks to FarmEvo for their consistent support to PNDS, and especially for providing the Zoom link at the very last hour. Thank you, FarmEvo. And thank you once again, everyone. And looking forward to more collaboration in the future. Have a great evening. Thank you.
Okay, thank you, Rabia. Thank you, everyone. Thank you, all of the participants, for your presence and patience. And I hope you would find it, you must be find this session very informative and useful for your practice. And thank you so much. Bye-bye.
Bye.